الرحيم، والصلاة والسلام على أشرف المرسلين سيدنا محمد صلى الله عليه وسلم وعلى آله وصحبه أجمعين. أهلا بكم جميعا. وطبعا أنتم كلكم عارفين والنهاردة يعني يوم خاص وليلة خاصة، لأن أنتم عارفين كلكم طبعا يعني إيه اللي إحنا فيه وإزاي دكتور وائل بحبح يعني ربنا ابتلاه بالمرض وإصابة الكوفيد 19، وإن شاء الله رب العالمين يعني ربنا سوف يعافيه بإذن الله. مش محتاج ان انا اتكلم او افيد في الكلام، يعني وائل بالنسبه لي ايه او انا بالنسبه لوائل ايه. صدقوني احنا الاثنين واحد، يعني عمرنا في لحظه من اللحظات لحد منا حس باي نوع من الغيره من الثاني، ولا اي وائل يتكلم محمد يتكلم وائل يظهر والله 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 النقطه دي بفضل الله، يمكن ده سر من نجاحنا ان شاء الله. أنا عاوز أقول كمية التفاعل، وحصلت نوع من المظاهرات على وسائل التواصل لما الناس عرفت إن وائل تعبان. وده يعني هو ربنا سبحانه وتعالى حب هذا الشخص، فعشان كده كان رياكشن طبيعي ورد فعل طبيعي ان الناس كلها تحبه. وده مصداقا لقول رسول الله صلى الله عليه وسلم: ان الله تبارك وتعالى اذا احب عبدا نادى جبريل ان الله قد احب فلانا فاحبه، فيحبه جبريل عليه السلام، ثم ينادي جبريل في السماء أن الله قد أحب فلانا فأحبوه، فيحبه أهل السماء ويوضع له القبول في الأرض. هذا اللي احنا حاسينه بفضل ربنا سبحانه وتعالى على الدكتور وائل بحبح، ان ربنا سبحانه وتعالى احبه يعني، وبناء عليه وضع ليه القبول عند الناس، وضع للقبول في الارض. فكل يعني بفضل الله انا بطمنكم ان هو يعني نوعا ما ومستقر نوعا ما عن امبارح، والامور الى حد ما بفضل الله احسن من امبارح، وده بفضل الله سبحانه وتعالى. ثم اعماله اللي هو بيعملها اللي كان لا يبتغي بيها الا وجهه عز وجل. دعواتكم كان لها يعني مفعول القوي جدا في ان ربنا عافاه جزئيا. وانا اتوجه الى الله سبحانه وتعالى دلوقتي بالدعاء، وارجو ان انتم تامنوا في هذا الدعاء باخلاص، لعل الله سبحانه وتعالى يستجيب لنا. ممكن يكون في عبد يعني من اللي بيسمعونا ان شاء الله، او سيده من اللي بتسمعنا، او دكتور او دكتوره، يعني يستجيب الله له سبحانه وتعالى. رجاء ان انتم تامنوا على هذا الدعاء باخلاص ويقين، حتى لو احنا تعبنا ربنا يسخر لنا اللي يدعي لنا باذن الله تعالى. اللهم صل على سيدنا محمد في الاولين، اللهم صل على سيدنا محمد في الاخرين، اللهم صل على سيدنا محمد في الملأ الأعلى إلى يوم الدين، اللهم صل على سيدنا محمد في كل وقت وحين. اللهم إني أسألك من عظيم لطفك وكرمك وسترك الجميل أن تشفي أخويا الدكتور وائل وتمده بالصحة والعافية. اللهم إنا نسألك بأسمائك الحسنى وبصفاتك العلى وبرحمتك التي وسعت كل شيء أن تمن عليه بالشفاء. اللهم من عليه بالشفاء العاجل، وألا تدع فيه جرحا إلا داويته، ولا ألما إلا سكنته، ولا مرضا إلا شفيته. اللهم ألبسه ثوب الصحة والعافية عاجلا غير آجل، عاجلا غير آجل، عاجلا غير آجل يا الله. اللهم اشفيه وعافيه واعف عنه، واشملنا بعطفك ومغفرتك، وتولنا برحمتك يا أرحم الأرحمين. إلهي أذهب البأس رب الناس، اشفي وأنت الشافي، لا شفاء إلا شفاؤك، شفاء لا يغادر سقما يا رب العالمين. اذهب البأس رب الناس، بيدك الشفاء، لا كاشف له إلا أنت يا رب العالمين. اللهم إني أسألك من عظيم لطفك وكرمك وسترك الجميل أن تشفي تشفيه يا رب العالمين وتمده بالصحة والعافية. لا ملجأ لنا ولا ينجى منك إلا إليك، إنك يا رب على كل شيء قدير. اللهم اكفه بركنك الذي لا يرام، واحفظه بعزك الذي لا يضام، واكلاه في الليل والنهار. رب الناس ملك الناس اذهب البأس واشف، أنت الشافي شفاء لا يغادر سقما يا رب العالمين. اللهم إنك على كل شيء قدير. أسأل الله العظيم، أسأل الله العظيم رب العرش العظيم أن يشفيك. اللهم اشفيه، اللهم اشفيه وعافيه يا رب العالمين. اللهم يا مسهل الشديد وملين الحديد ومنجز الوعيد، ويا من توكل كل يوم في أمر جديد، أخرج مرضانا من حلق الضيق إلى أوسع الطريق. اللهم ألبس أخونا الدكتور وائل ثوب الصحة والعافية عاجلا غير آجل، عاجلا غير آجل يا أرحم الراحمين. أسأل الله العظيم أن يشفيك شفاء لا يغادر سقما يا رب العالمين. اللهم اشفه شفاء ليس بعده سقما أبدا. اللهم خذ بيده، خذ بيده، خذ بيده. اللهم احرسه بعينك التي لا تنام، احرسه بعينك التي لا تنام، واكفه بركنك الذي لا يرام، واحفظه بعزك الذي لا يضام، واكلاه في الليل والنهار. وارحمه بقدرتك، اللهم ارحمه بقدرتك. أنت ثقته، اللهم أنت ثقته ورجاءه. اللهم يا كاشف الهم، يا كاشف الهم ويا مفرج الكرب، يا مجيب المضطر. اللهم يا مجيب المضطر، يا مغيث، يا حي يا قيوم، برحمتك نستغيث. اللهم أغثنا، اللهم أغثنا واشف أخونا وائل. اللهم يا رب ارفع هذا البلاء وهذا الوباء. اللهم إنا نسألك بكل اسم هو لك سميت به نفسك، أنزلته في كتابك، أو علمته أحدا من خلقك، أو استأثرت به في علم الغيب عندك، أن تشفيه يا رب شفاء عاجلا عاجلا غير آجل. وصل اللهم على سيدنا محمد صلى الله عليه وسلم. النهارده إن شاء الله معانا يوم إن شاء الله في الاندوكراينولوجي الموجة الثالثة، وهتبقى عن الديابيتس بإذن الله. دكتورة رشا، دكتورة رشا، دكتورة رشا.
مساء الخير يا دكتور محمد، ازيك؟
حضرتك ازاي حضرتك؟
مساء الخير على الكل.
مساء النور، ربنا يبارك فيك يا دكتورة رشا.
ربنا يخليك يا دكتور محمد.
خليك.
عايزه اشكرك طبعا على الدعوه، وطبعا بشكر الدكتور وائل وبدعي له والله من كل قلبي ربنا يعلم، والحاجه ملهاش طعم من غير ما يبقى موجود. ان شاء الله يقوم بالسلامه، وربنا يتقبل دعاء الناس اللي بتحبه، ويبقى كويس وبخير وينور الدنيا زي الاول واحسن ان شاء الله باذن الله. ان شاء الله كل حاجه تبقى جميله ويرجع ينور الدنيا تاني ان شاء الله. ربنا يتقبل الدعاء.
ان شاء الله، يعني ربنا عمره ما هيخلي لنا رجاء ولا امل. أكيد. باذن الله.
اكيد. حب الناس، حب الناس ودعائهم يا رب يكتب له الخير كله وينور الدنيا تاني ان شاء الله باذن الله
يا رب. دكتوره بسمه، دكتوره بسمه، دكتوره امينه.
اهلا يا فندم.
السلام عليكم.
وعليكم السلام ورحمه الله وبركاته. ازيك يا دكتوره بسمه؟
ازي حضرتك دكتور محمد؟ ازي حضرتك؟
ربنا يحفظك ويبارك فيك يا رب. ربنا يحتوي
ان شاء الله. ربنا يطمنا على دكتور وائل باذن الله، واذا احب الله عبدا ابتلاه، فان شاء الله ربنا سبحانه وتعالى يجعل ده في ميزان حسناته ان شاء الله.
ان شاء الله باذن الله يا رب العالمين.
ان شاء الله ربنا يشفيه تمام الشفاء ان شاء الله. وفعلا هو
كفايه ان
ربنا
هو مجمعنا كلنا الليلات يعني، فاكيد يعني هيوصلوا الثواب ان شاء الله. علم ينتفع به.
ربنا يا رب يجعله في ميزان حسناتنا جميعا يا رب، جميعا يا رب. الدكتوره دعاء ان شاء الله معانا النهارده، وهي اللي عليها الحمل كله. دكتوره دعاء خاطر، استاذه طب الاطفال والغدد الصماء في الاطفال لكليه طب جامعه اسكندريه، وان شاء الله هي المنسق العام للجلسه بتاع النهارده، وعليها الحمل كله. دكتوره دعاء، دكتوره دعاء، ايوه المايك يا دكتوره دعاء.
تمام. ايوه مع حضرتك يا فندم، اهلا بحضرتك.
اهلا بيكي، اهلا وسهلا يا دكتوره دعاء، مشرفينا ان شاء الله، والنهارده ان شاء الله يبقى يوم مفيد باذن الله لكل الناس يا رب،
يا
باذن
رب
الله.
امين، يا رب امين. شكرا جزيلا دكتور محمد بجد على المقدمه الجميله وعلى الدعوه الكريمه وعلى الدعوات اللي حضرتك وجهتها للدكتور وائل، والشكر موصول برضو للدكتور وائل، ربنا يشفيه يا رب ويعافيه
يا رب.
ويجعل في ميزان حسناته الابتلاء اللي هو بيمر بيه. ولو حضرتك بصيت على الشات بوكس هتلاقي كل الناس وكل الاتندي عمالين يدعوا له، كلها دعوات خالصه، كلها دعوات من قلبهم. ربنا ان شاء الله يعني يشفيه شفاء عاجل غير اجل ان شاء الله.
يا رب العالمين. اتفضلي اتفضلي يا دكتوره دعاء، اتفضلي.
النهارده حضرتك يعني اخترت لنا موضوع جميل جدا وموضوع اوف انترست لكل الناس، اللي هو الدايابيتس. كلنا عارفين ان type 1 diabetes is the most common type of diabetes in children and young adults. It's a unique entity, unique لان هو الباث فيسيولوجي بتاعه unique, الدايجنوزز unique, and the management challenges also unique. The management challenges in day-to-day treatment, in sick day management, and also in the life-threatening complication, which is the diabetic ketoacidosis. All of these and more today will be addressed in our webinar, in our third pearl in the endocrine chain, by our three eminent and our three distinguished speakers, أستاذة دكتورة رشا طريف, أستاذة دكتورة بسمة عبد الواعز, and أستاذة دكتورة أمين عبد الوهاب. يا رب نفيد ونستفيد ويكون ويبينار جميل وميت يور اكسبكتيشنز. اند بدعوكم كلكم تجهزوا طبعا الشاي والسندوتشات عشان عندنا سهرة طويلة، واليوم هيبقى يعني حافل ودسم ان شاء الله. وبس عايزه انوه ان الاسئله يا ريت تتكتب في الكيو ان اي بوكس مش في الشات بوكس، علشان يعني نشوفها كلنا بطريقه اسهل. هنبدا النهارده مع اول سبيكر، مع استاذتي وحبيبتي وحبيبه الكل، نجمه جماهير الاندوكراين كلهم اللي مشرفانا في كل المحافل القديره، البروف رشا طريف. دكتورة رشا طريف أو أستاذة دكتورة رشا طريف is a professor of pediatric and pediatric endocrinology in Ain Shams University. She is the chair of education and training committee in the European Society of Pediatric Endocrinology, and she's the vice president of the Arab Society of Pediatric Endocrinology and Diabetes. دكتورة رشا هتدينا overview عن ال type 1 diabetes and beyond. All of us are curious to know what is beyond. بروف رشا, the screen is yours.
ميرسي. ثانك يو فيري ماتش يا دعاء، ميرسي على المقدمه الجميله يا حبيبتي، بشكرك عليها. نعمل بس شير سكرين. تمام. زي ما دعاء قالت الحقيقه البيدياتريك دايابيتس من الحاجات التوبكس الهوت توبكس اللي هي بتهم كمان الجنرال بيدياتريشنز، مش بس احنا كبيدياتريك اندوكراينولوجيستس، لا ناس كتير قوي بتشوف حالات دايابيتس وبتعمل مانجمنت. والتوبيك اللي انا حطيته بيدياتريك دايابيتس تايب 1 اند بيوند، والحقيقه انا سميتها كده لان تايب 1 هو الموست كومن، بس في حاجات تانية برضو لازم نفكر فيها not only type 1. Of course, pediatric diabetes is a growing problem, not only in Egypt, but worldwide. When facing a newly diagnosed diabetic child, the questions that come to our mind are, is it diabetes or pre-diabetes? Which type of diabetes? Are there any associated comorbidities? Is it insulin or oral therapy? The first question, is it pre-diabetes or diabetes? And let's take this quiz. Please vote with me. Answer this question. Help me in the diagnosis. This is a 10-year-old child with fasting blood sugar, 136 milligrams per dl, hemoglobin A1C 8.2. What is the provisional diagnosis? Is it diabetes, pre-diabetes, or normal? Please vote with me.
Dr. Rasha, can you see the results?
No, I couldn't. Yes, thank you. Okay, thank you very much. Yes, most of you got the correct answer. 86%, more than 85% said it is diabetes. Indeed, this is the definition of diabetes. The blood sugar, fasting blood sugar more than 126, and the A1C, of course, here is high. Now let's go to the following question. This is another 10-year-old child, fasting blood sugar 114 milligrams per dl, A1C 6. What is your diagnosis? Is it diabetes, pre-diabetes, or normal? Please vote. Yes, thank you very much. Most of you got the correct answer. This is a case of pre-diabetes. Now, looking into the definitions of diabetes and pre-diabetes, diabetes is diagnosed if hemoglobin A1C is more than 6.5, fasting blood sugar more than or equal 126 milligrams per dl, or glucose tolerance or 2-hour postprandial more than 200. Pre-diabetes is diagnosed if A1C is from 5.7 to 6.4, the fasting blood sugar 100 to 125, and oral glucose tolerance or 2 hours postprandial 140 to 199. So you've got most of the correct answers. Looking into the childhood diabetes is classified into either type 1 diabetes, of course, this is the most common, type 2 diabetes, which is becoming common, monogenic diabetes, uncommon, and secondary diabetes. The monogenic diabetes is classified into either due to beta cell dysfunction or insulin receptor defect like lipodystrophies, or monogenic autoimmunities like APCAD, autoimmune polyendocrinopathy type 1, and IPEX. And the beta cell dysfunction of the monogenic type is mainly due to either MODY, maturity onset diabetes of youth, or neonatal diabetes. So this is the main skeleton that we are going to work upon. Looking into childhood diabetes, of course, type 1 diabetes by far is the most common type of diabetes. When you see a diabetic child, it's type 1 until proved otherwise. But when to consider non-type 1 diabetes? Consider type 2 diabetes if there is no islet cell autoantibodies, obesity, acanthosis nigricans, high C-peptide, and family history of type 2 diabetes. When to say monogenic diabetes? Diabetes in the first 6 months of life, extra pancreatic features, mild stable fasting hyperglycemia, diabetes in more than 2 generations without typical features of type 2 or type 1. And then we have the secondary diabetes due to either steroids, chemotherapy, thalassemia, or sickle cell disease. Now, let's start by the story of this boy. This is a 6-year-old boy. He presented with DKA. He was misdiagnosed as pneumonia because he was tachypnic and the doctors thought it is due to pneumonia, but actually it is acidosis. There was history of polyuria and polydipsia with no family history of diabetes. His mom has Hashimoto's thyroiditis. There is no history of drug intake. He's not obese. He doesn't have acanthosis nigricans. His hemoglobin A1C is very high, 13.8. A very low C-peptide. The fasting and the postprandial blood sugar are very high as well, as you see here, and he presented with acidosis. Now, which type of diabetes? Please vote with me. Help me in diagnosing this child. Is it type 1 diabetes, or type 2 diabetes, or monogenic diabetes, or secondary diabetes? Please vote. Yes, thank you very much. Of course, it's clear it's towards type 1 diabetes. As we said, it's the most common type, and these criteria fit with type 1. It's not type 2. The boy is not obese. No acanthosis nigricans, no insulin resistance. The C-peptide is not high, it's low. So it's not type 2. It's not monogenic. There is no family history or any of criteria we mentioned, and it is not secondary diabetes. There is no history of drug intake or any previous chronic illness. Of course, the diagnosis of childhood type 1 diabetes is very easy. Most of them present with DKA, which will be discussed by Professor Basma, and some of them come walking wounded, a random blood sugar more than 200 with symptoms like polyuria, polydipsia, weight loss, nocturnal enuresis. Rarely, it could be asymptomatic with A1C above 6.5, fasting blood sugar more than 126, and the 2 hours more than 200. And these are ISPAD guidelines criteria in 2018. But sometimes it is not that easy. There are some barriers in accurate diagnosis of the type of diabetes, because there is a threefold increase in the family history of type 2 diabetes in patients with type 1. There is an overlap of C-peptide measurement at the onset and the first year, so sometimes it's not accurate at the beginning. 20 to 25% of newly diagnosed type 1 patients are obese. More than 15% of type 1 populations have family history of type 2. 10 to 30% of pediatric type 2 diabetics have diabetes-specific autoimmune markers. And finally, more than 30% of type 2 have ketosis at the disease onset. So as you see, there aren't clear-cut features all the time. There is a degree of overlap between type 1 and type 2. We all know the natural history of type 1 diabetes, a viral trigger in the presence of some genetic predisposition, causing initiation of autoimmune response, with B-cell injury entering into the phase of prediabetes until it presents with diabetes, and at that time, less than 15 to 20% of the beta cells function remain. Looking at the complications of type 1 diabetes, there are some complications. On top of the list is the DKA, chronic micro and macrovascular complications, and associated autoimmune disease. The long-term complications are related to hyperglycemia, degree of control, and its duration. We have the microvascular complications like retinopathy, nephropathy, and neuropathy, and the macrovascular affecting medium and large blood vessels, causing coronary, cerebrovascular disease, and peripheral vascular disease. And there are some endocrinopathies and autoimmunities beyond type 1 diabetes associating the disease, like short stature, delayed puberty, Hashimoto's thyroiditis or Graves' disease, Addison's disease, very uncommon but could be there, celiac disease, and it could be part of autoimmune polyendocrinopathy types 1 and 2. Growth failure in type 1 diabetes is due to a sort of growth hormone resistance, and optimizing hemoglobin A1C improves the growth. It's not recommended to start growth hormone therapy in such patients. It's better to improve A1C to improve the growth of those children. Delayed puberty depends on duration, BMI, and hemoglobin A1C. Again, it is related to degree of glycemic control to establish and start puberty. Sex steroids create a degree of insulin resistance, increasing the insulin requirements, and therefore higher insulin doses are needed during puberty and at the time of menses in girls than the rest of the months due to degree of insulin resistance associating sex steroids. And don't forget this very important list proposed by ADA. 3 monthly follow-up of weight, height, Tanner staging, blood pressure, A1C. Yearly follow-up of fundus 5 years after the start of disease, microalbumin in urine, fasting lipid profile, liver and kidney functions, calcium, vitamin D, celiac screen, thyroid, and Addison if suspected. And don't forget the psychological assessment, which is extremely important in those children and the families. And as an example of associated comorbidities, let's start the story of this 11-year-old girl. This girl was diagnosed as having type 1 diabetes at the age of 6 years. She started to develop slowing of growth and weight gain. She also has frequent attacks of hypoglycemia, which is not explained. The total daily dose of insulin is getting lower. Her aunt has got Graves' disease. She's short, her height is -2.5, and her BMI is towards the high side, +1.2. Now, this is the growth chart of the girl. She had normal height since birth and at the start of diabetes, but then started to decelerate and plateau her height. And then the weight was normal since birth and during the course of diabetes. And then she started to develop weight gain in spite of low A1C. So we have a girl with type 1 diabetes who plateaued her height and started to gain weight. Please vote with me here. What is the most important investigation for such a girl? Is it celiac screening, thyroid function test, growth hormone provocation test, or GnRH stimulation test? Please help me. What would you like to choose for this girl? Gaining weight, not gaining height? Yes, thank you very much. Most of you got the correct answer. Of course, we need to do thyroid function test because she's not gaining height and she's gaining weight. Celiac disease will have weight loss. They will not gain weight. And of course, we do not need to do growth hormone provocation in this girl. You need to assess the thyroid first. And there is no place for GnRH stimulation test because she's not complaining of any pubertal disorder. Okay. Now, we did the thyroid function. We found low T4, high TSH, primary hypothyroidism, and the antibodies were positive. The bone age is delayed, and of course, the diagnosis was easy here. This is a case of Hashimoto's thyroiditis on top of or associating type 1 diabetes. And the A1C kept going low, and the celiac screening to confirm was negative. Now, thyroxine was added, and the girl gained very nice height, and she started to normalize and lose weight. So the conclusions here are Hashimoto's thyroiditis is a common association with type 1 diabetes. Suspect hypothyroidism in a diabetic child if there is slowing of growth, weight gain, and delayed bone age. Unexplained attacks of hypoglycemia is commonly encountered in patients with type 1 developing hypothyroidism. Yearly screening of thyroid function in children and adolescents with type 1 is very important because it's quite a common association. Unexplained low hemoglobin A1C is another clue. Treatment of hypothyroidism results in catching up growth and weight loss. Of course, management of childhood diabetes is a very important issue. And this nice pyramid was proposed by ISPAD, IFD, and WHO. The base of the pyramid, as you see, is education. Education of the patient and the family regarding the diet, the insulin, the exercise, and the whole lifestyle. It needs a multidisciplinary team and frequent glucose monitoring because there are a lot of challenges to face when dealing with a child with type 1 diabetes. We need to maintain normal growth, puberty, and scholastic achievement, normal family routine, reducing the complication, and finally, smooth transition to adult service. Indeed, there should be perfect collaboration between the child, the parent, and the school, working together with the pediatric diabetologist in between, arranging and linking and filling the gaps between them. Starting by insulin therapy, according to ADA guidelines, the dose is 0.4 to 0.8 unit per kg per day, increased to 1 unit per kg per day. And of course, at puberty, larger doses are needed, up to 1.2 to 1.5 units per kg per day. Of course, in children, we need multiple dose basal bolus injection or continuous infusion by the pump. The dose is classified as 50%, 40 to 50% of the total daily dose basal, and the bolus is 50 to 60% divided on the 3 meals. It's very important to educate on how to match the prandial insulin according to carbohydrates, pre-meal blood glucose, and anticipated activity. All of this is part of the education. And the use of insulin analogs in very young children is preferred to reduce the risk of hypoglycemia. If you look at this curve, you can see various types of insulin. The main idea is combining short and long acting with various degrees. You can use ultra short or regular combined with either NPH twice a day or Glargine once or twice a day or Detamir twice a day or Degludec, which is the most recent, once a day because it covers more than 24 hours. Any combination is possible. And here you can see a table showing different types of insulin according to onset of action, peak of action, and duration. But the golden rule is avoid pre-mixed insulin in children. We always have to combine short and long-acting forms together. Of course, different sites absorb insulin at different areas. The fastest is the abdomen and the slowest is the thigh. It's very important to rotate the sites of injection to avoid lipodystrophy and to improve the absorption. Finally, the management should be individualized for each diabetic child because each diabetic child has got his or her particular story. Coming to blood sugar correction factor, this is what we call 1,800 rule. I'm sure Professor Amina will discuss this in detail in the sick day management. What we do is that we divide 1,800 on the total daily dose of insulin. And this will give you milligrams per deciliter of blood glucose that will be lowered by 1 unit of ultra short acting insulin. Now let's take an example to apply this. If a child is taking a total daily dose of insulin 20 units per day, ultra short and Glargine together. So the blood sugar correction factor is 1,800 rule divided by the total daily dose. So we divide 1,800 by the total dose of 20, so you get 90. This means each unit of ultra short insulin will lower the blood glucose by 90 milligrams per deciliter. We all know and hear about the insulin pump, a very nice invention, but indeed it needs proper education about the carb counting. It needs highly motivated and educated parents to deal with. Diet adjustment is another cornerstone. We need a dietitian skilled in diabetes. 3 meals, 2 to 3 snacks. Meals and snacks should be balanced because we've got certain goals: healthy eating pattern, maintaining growth and puberty, achieving proper glycemic, lipid, and blood pressure goals, and finally preventing complications. And this is how the plate should look like. Carbs, 55%, fat, 30%, proteins, 15%, with a lot of high fiber diet. This is the plate of a diabetic child. A lot of greens, half the plate carbs, and the rest proteins and some fat. What about the carb counting? The carb counting has certain rules to apply. Each 15 grams of carb is equal to 1 dot in calculation. And the insulin carb ratio is calculated by the 500 rule. This is by dividing 500 on the total daily dose of insulin. And this is for rapid acting insulin. The amount of carb in grams burned by each 1 unit of rapid acting insulin. Sometimes there are tables that you could check to check the carb counting and calculate the insulin dose, or you can calculate it by yourself. The physical activity is very important. Encourage moderate regular physical activity. 60 minutes a day is adequate. Safe pre-exercise blood sugar should be more than 100 to avoid hypoglycemia. Reduce the prandial insulin dose for the meal or snack preceding the exercise. And sometimes we reduce the basal insulin the night before exercise to avoid delayed hypoglycemia. It could extend up to 16 hours. So you have to reduce the basal insulin as well. Looking into the daily life of a diabetic child, it is really miserable. And those children feel different, which makes the management even more difficult. So please pay attention to the impact of psychological status on the outcome of type 1 diabetes. The children, their parents, the whole family need a lot of psychological support, not just prescribing insulin and adjusting the diet. So the conclusions on type 1 diabetes is the most common type of diabetes in children. The BMI is usually normal, not obese, but sometimes they could be obese, with no acanthosis nigricans. Commonly present with DKA. C-peptide is usually low, but as we said, it's not conclusive at the onset and the first year. Autoantibodies are usually positive, but not in every case. Insulin multiple dose regimen is the cornerstone of treatment, and of course, there is no place for oral therapy. It's insulin combined with diet, exercise, and education. Now, the other side of the spectrum, obesity. We finished type 1. Let's go to obesity. Obesity epidemic is becoming a global health problem, not only in Egypt, but worldwide. And Egypt is the second among Arab countries, world's fattest countries. Egypt is one of them. And Egyptian children were classified among the world's 10 heaviest children all over the world. We have a lot. Childhood obesity in Egypt is alarming. Let's go for this girl, the other spectrum, the other story. A girl, 11-year-old, who has progressive weight gain since 6 years. She does not have polyuria or polydipsia, but she has sleep apnea due to obesity. There is no history of drug intake. Her IQ is normal. There is type 2 diabetes in her grandma. She is tall. Her BMI is very large. She is obese. She has abdominal obesity. Her waist-hip ratio is high. As you see in the photo, she has acanthosis nigricans, and her blood pressure is high. She's hypertensive. Her fasting blood sugar is high, 187. Insulin is very high. The HOMA-IR is high. The A1C is high, 8.8, and the C-peptide is high as well. Which type of diabetes? Please help me. What is the most probable diagnosis of this girl? Please vote. Is it type 1 diabetes, type 2 diabetes, monogenic diabetes, or secondary diabetes? Please vote. Help me in the diagnosis. An obese girl having acanthosis nigricans, high insulin, high C-peptide, asymptomatic. What do you think? Thank you very much. Nearly 87%, excellent, got the correct answer. Yes, this is a case, probably this is type 2 diabetes. Of course, it's not type 1. She's extremely obese. She has acanthosis nigricans. The C-peptide is very high. It's not monogenic. There is no genetic history going through the family. It's only her grandma. And it does not fit the criteria of monogenic diabetes, as I will show you. It's not secondary diabetes because she did not take any drugs like steroids and she doesn't have any chronic illness. So the answer is type 2 diabetes. Of course, a lot of factors enter in the pathogenesis of type 2 diabetes. There is altered gene and protein expression triggered by obesity, inactivity, and dietary excess, in addition to family history and other risk factors, causing what we call glucolipotoxicity, creating a degree of B-cell dysfunction and insulin resistance, ending up by type 2 diabetes. Now, when we looked into the other profile of that girl, we found a very high cholesterol, triglycerides, LDL, while the HDL was low. She has got dyslipidemia as well. Her liver enzymes are high. Thyroid and Cushing were ruled out. It's not endocrine, and she's very tall. She couldn't be endocrine. Ultrasound revealed grade 2 fatty liver. So looking a closer look to that girl, she has metabolic syndrome, and type 2 diabetes is part of her metabolic syndrome. And when we look into obesity, obesity is the tip of the iceberg, while the hidden part of the iceberg that we don't see is insulin resistance, type 2 diabetes, hypertension, dyslipidemia, PCOS, and a lot of other factors that we need to screen for. So this girl has got metabolic syndrome. And there is the phenomena of what we call obesity-induced inflammation. Abdominal obesity triggering a low-grade inflammatory state, increasing the tumor necrosis factor alpha, interleukin-6, and CRP, increasing the risk of cardiovascular disease, triggered by insulin resistance, hyperinsulinemia, hypertriglyceridemia, and low HDL. Again, increase in the free fatty acid plays a key role in creating a state of insulin resistance, ending by type 2 diabetes. The free fatty acids increased gluconeogenesis in the liver, decreased glucose uptake by the fat cells, decreased glucose uptake, oxidation, and glycogenesis in the muscle. And finally, there is impaired glucose-stimulated insulin secretion, ending by type 2 diabetes. Now, please help me in treating that girl. If you have asymptomatic, obese, diabetic adolescent, what is the first line of treatment? This is a case of type 2 diabetes. Asymptomatic, what would you like to give to that girl? Please vote. Would you like to start insulin drip or subcutaneous insulin, or metformin and lifestyle changes, or subcutaneous insulin combined with metformin. And bear in mind, she's asymptomatic. Her A1C is less than 9, 8.8. What would you like to do here? Excellent. Thank you very much. 95% got the correct answer. Definitely the answer here is metformin and lifestyle changes. Yes. Looking into the ISPAD clinical practice consensus guidelines on management of type 2 diabetes in children and adolescents, if the adolescent is asymptomatic and the A1C is less than 9 with no acidosis, and this fits with our case, give metformin and lifestyle change. If symptomatic, A1C more than 9, no acidosis, combine basal insulin, metformin, and lifestyle change. If the patient presents with DKA, you have to start drip and then wean the patient and go back to basal insulin and metformin. And then it's better to do the antibodies to classify whether it's really type 1 or type 2 and treat accordingly. So our case is asymptomatic. The A1C is less than 9. So the correct answer is metformin and lifestyle change. And this is what we did. She was put on dietary advice, regular exercise, and metformin 1,500 milligrams a day. 3 months later, she lost weight. A1C dropped very nicely. Dyslipidemia improved and her blood pressure normalized. So the good news is that type 2 diabetes is preventable and it could be reversible. And of course, this is not the case in type 1. So type 2 could be prevented and could be treated as well. The conclusions in type 2 diabetes are: type 2 diabetes in children is becoming more common than before due to rising prevalence of obesity. Type 2 diabetes in children and adolescents is usually asymptomatic, but they could present with ketosis. Acanthosis nigricans is a sign of insulin resistance directing you towards type 2 diabetes. Type 2 diabetes could be part of metabolic syndrome. Don't forget to screen for other features of metabolic syndrome. Type 2 diabetes is preventable to a great extent, and the first-line treatment in asymptomatic type 2 diabetic cases is a healthy lifestyle and metformin. And then we go to the less common types of diabetes, what we call the monogenic diabetes. And by monogenic diabetes, we mean diabetes due to single gene defect. It's either inherited or sporadic. And it's further classified into defects due to either B-cell dysfunction, insulin receptor defect, or what we call monogenic autoimmunity. Now, the B-cell dysfunction, on top of the list, we have the MODY diabetes and the neonatal diabetes, and some rare syndromes like Wickett-Rallison syndrome and mitochondrial diabetes as well. For the insulin receptor, don't forget to exclude lipodystrophy. And for the monogenic autoimmunity, we have autoimmune polyendocrinopathy type 1, the APCAT, and the IPEX and IPEX-like syndrome. So these are the criteria proposed by ISPAD, Clinical Practice Consensus Guidelines 2014, when to consider monogenic diabetes. Diabetes in the first 6 months of life. If the patient has extra pancreatic features, if there is mild, stable, fasting hyperglycemia, strong family history of diabetes in patients who lack typical features of type 1 and type 2. So if you want to take it easy, it doesn't fit with type 1 and it doesn't fit with type 2 typically. Type 1 diabetes is unlikely if you have no islet cell antibodies. Unlikely, it's not absolute. And if the C-peptide is more than 200 picomole per liter 5 years after diagnosis. Type 2 diabetes is unlikely if there is no marked obesity and no acanthosis nigricans. So if you find the features not fitting with type 1 or type 2, think of monogenic diabetes. Let's see the story of this 15-year-old adolescent boy. He came with mild polyuria and polydipsia. He has some mild weight loss, but his BMI is normal. There is no acanthosis nigricans, no extra pancreatic features. The father was diagnosed as having diabetes at the age of 33 years and was put on insulin. There is no history of drug intake. The boy has glucosuria, but no ketonuria. And the A1C is high, 7.1, but not that high like the type 1. The oral glucose tolerance revealed a glucose of 230 milligrams per dl. The C-peptide is normal and the antibodies are negative. Now, help me please in diagnosing this boy. What is the most probable diagnosis? Does it fit with type 1? Please vote. Does it fit with type 1 diabetes or type 2 diabetes or early onset MODY diabetes or secondary diabetes? Please vote, help me in this puzzle. Adolescent, C-peptide normal, no antibodies, not obese. Thank you very much. Yes, 95% got the correct answer. This is early onset MODY. Definitely, it doesn't fit with type 1. Type 1 would have been more aggressive. It's not type 2, no acanthosis, no insulin resistance. It's not secondary. The boy did not have any history of drug intake or chronic illness, so this is early onset MODY. So when to think of MODY? It's an autosomal dominant disease. The onset is usually less than 25 years, usually at adolescence. Non-ketotic diabetes. Remember, the boy had glucosuria with no ketonuria. Remember, sporadic cases can occur. Obesity does not exclude MODY, and MODY is extremely heterogeneous condition. Now, the boy was put on dietary advice, small dose glargine, and 3 months later, the A1C is still high. It didn't go lower. It's not very high, but it didn't improve a lot. What is the most decisive investigation in such a boy? How could you reach the final diagnosis? Please vote and help me in that. What would you like me to do? Is it genetic testing, repeat hemoglobin A1C, fasting glucose and insulin, or investigate to exclude extra pancreatic features? When you are suspecting a MODY diabetes, how would you like to confirm the diagnosis? Excellent, yes. More than 75% got the correct answer. Of course, it's genetic testing. Yes, none of you chose the A1C, and fasting glucose insulin will not add a lot of information, and the boy doesn't have any other complaint to exclude other extra pancreatic. What we do is genetic testing. And what happened to that boy? Direct sequencing of HNF1 alpha gene revealed heterozygote mutation of the child and his father, confirming MODY type 3. The father was misdiagnosed in the past as being type 1. Actually, the father is not type 1. The father and the child are MODY 3. And the good news is that there is response to oral sulfonylurea, glycoside. And look how nicely the A1C went down when the child was shifted on sulfonylurea. So it's very important to diagnose these cases because they could respond on oral therapy even better than insulin. MODY has got a lot of genetic cases. It's either due to transcription factor defect, like the case that you have seen, HNF1 alpha, MODY 3 in 20 to 50%, or other types of MODY, as you see here, a lot of MODY mutation, or could be MODY 2, which is the glucokinase defect, 22 to 60% of cases. Let's see this 8-year-old boy. The boy was diagnosed with asymptomatic hyperglycemia. It was accidentally discovered. The fasting blood sugar is 144. The postprandial is 182. And the reason why this boy was discovered is that he's got a very obsessive mother. The mother keeps checking the blood sugar of her children due to presence of a family history, and because the mother herself experienced during pregnancy a degree of hyperglycemia. So she keeps checking up her children's blood sugar, and this is what they found: accidentally discovered asymptomatic hyperglycemia. There is no glucosuria, no ketonuria. The A1C is just high, 6.6, negative antibodies, normal C-peptide, normal weight, no acanthosis nigricans. And as I told you, the mom experienced mild hyperglycemia during pregnancy. What do you think? Could it be pre-type 1 diabetes, type 1 coming on the way, or is it MODY? Okay, what shall we do to differentiate? If we need to cut it short and get the answer, please vote. Which one of these could differentiate? Would you like to repeat the C-peptide, or fasting glucose and insulin, or do genetic testing, or investigate to exclude extra pancreatic features? I need to know, is it pre-type 1 diabetes going on the way, or is it MODY diabetes? Excellent, thank you very much. You got the message. Yes, definitely genetic testing is the thing that will differentiate, because as we said, all types of monogenic diabetes, including MODY, are genetic. And this is what we did. Direct sequencing of glucokinase gene revealed heterozygote mutation MODY2 diabetes. And most of the MODY2, as you've seen, is accidentally discovered. It's asymptomatic and accidentally discovered. And they can maintain a good blood sugar just on the diet and healthy lifestyle without treatment. So we finished the first type, the MODY diabetes, the first of monogenic. Let's go to another type of monogenic diabetes, what we call the neonatal diabetes. From its name, it's diabetes diagnosed in the first 6 months of life. 45% are transient, but sometimes it relapses in half of them. 45% are permanent, and 10% are syndromic or due to pancreatic aplasia. As you see, a lot of genetic mutations are involved in that. Now, the clinical presentation is totally variable. It could be an incidental finding. It could be symptomatic hyperglycemia, a newborn who is not doing well, vomiting, dehydration, lethargy, poor feeding, failure to thrive. Please, if you have a neonate who's not doing well, don't forget to measure the blood sugar and electrolytes. Or could come in a bad general condition presenting with DKA. Everything is possible with neonatal diabetes. Look at this 4-month-old infant. He was born full term. He presented at the age of 4 months with recurrent vomiting, poor feeding, weight loss, convulsions, and he developed developmental delay and mental affection later on. There is no family history of diabetes here. His random blood sugar is very high. The A1C is 9.3, very high. The C-peptide is low, but the antibodies are negative. He was started on insulin, 0.2 unit per kg per day, but the boy is not responding, and the doses were increased to reach 1 unit per kg per day. What is the suggested investigation that could influence the treatment here? Please vote. What would you like to do for this boy with neonatal diabetes? We have a neonate with diabetes. We need to find a cause for this and to treat accordingly. Would you like to repeat the C-peptide, or do genetic testing, or fasting glucose insulin, or investigate to exclude other endocrinopathies like thyroid, adrenals, and other endocrine glands? What would you like to do for this neonate? Excellent, thank you very much. Again, genetic testing. For any type of monogenic diabetes, the key is in genetic testing. Repeating the C-peptide will not add glucose insulin, and as well, we do not need to exclude other endocrinopathies here. So, the boy, newborn, was found to have a KER6.2 mutation here, and the good news is that he was switched from insulin to oral sulfonylurea, glibenclamide, and look how nicely the A1C went down. So this is neonatal diabetes due to KER6.2 mutation responding to oral sulfonylurea. So this is a real revolution in diabetes that preserves attention and that needs to do the genetic testing for. The KER6.2 infancy onset diabetes is the most common cause of neonatal diabetes in the first 6 months. 90% due to spontaneous mutations. 30% present with DKA with no C-peptide. 20% have DEND syndrome, developmental delay, epilepsy, and neonatal diabetes. And 10% have transient neonatal diabetes, which could relapse later in half of the cases, as we said. Remember that the majority secrete insulin in response to oral sulfonylurea, and better control on sulfonylurea than insulin. So my message here is that genetic testing should be done to any case of neonatal diabetes, regardless the clinical features, because simply it could be a mutation responding to oral sulfonylurea instead of giving insulin throughout life. These are 2 papers. The first published in New England Journal of Medicine, 2006, switching insulin to oral sulfonylurea in patients with diabetes due to potassium ATP channel mutation. This is KER 6.2, 90% success rate on sulfonylurea. And the diagram on the right is for SIR1 mutation. Again, 85% success on oral treatment. Again, this is a real revolution that deserves attention. Patients with diabetes diagnosed in the first 6 months of life should be tested for potassium ATP mutations to be given a trial of oral sulfonylurea instead of insulin. So the monogenic diabetes conclusions are: monogenic diabetes is the least common type of diabetes, but please think of it. There are a lot of subtypes due to various genetic mutations. Genetic testing is very important for monogenic diabetes, whether MODY or neonatal, because it can influence the clinical management of monogenic diabetes, unlike type 1 and type 2. In monogenic, it's very important. Now, another 10-year-old boy, let's go to the monogenic autoimmunities. The boy was diagnosed as type 1 at the age of 8. He is not compliant. He developed recurrent carpopedal spasm and generalized tonic convulsion. The boy also has mucocutaneous candidiasis, which was diagnosed before the onset of diabetes, not responding to usual lines of treatment. His total daily dose of insulin is quite high, 1 unit per kg per day. His mom has Hashimoto's thyroiditis. His weight and height are normal. Now, you have a boy with carpopedal spasm. What is the urgent lab investigation? Please help me. What would you like to do? Would you start with serum calcium, phosphorus, alkaline phosphatase, parathyroid hormone, or thyroid function test, or repeat hemoglobin A1C, or cortisol and ACTH9-EM? A boy with type 1 diabetes and carpopedal spasm. Where is the correct answer here? Urgent. Excellent. 95% got it. Yes. Serum calcium, phosphorus, alkaline phosphatase. This is a carpopedal spasm. Of course, other labs are not important in such a case. So we found very low calcium, a very high phosphorus, low parathyroid hormone, and the diagnosis here was hypoparathyroidism, for which alpha-calcidol and calcium were started. So the boy has got type 1 diabetes and hypoparathyroidism. Not only that, when the mom consulted the dermatologist because the child is losing his hair and his teeth look abnormal, he was diagnosed as having ectodermal dysplasia. In addition, he started to slow his growth in the last 2 years and to gain weight, in addition to poor scholastic achievement. He also has some easy fatigability, and now he is short. His height is -2.5. He's gaining a lot of weight. He has unexplained improvement of his hemoglobin A1C. The dose of insulin is going low, in spite of the fact that the boy is not compliant. Let me show you the chart of that boy. He had normal growth in birth and childhood, even the time when he had diabetes. But recently, he plateaued his height. And his weight was normal since birth and diabetes. Recently, he's gaining a lot of weight. So we have a child with type 1 diabetes and hypoparathyroidism and ectodermal dysplasia who is developing weight gain and short stature. What is the most important investigation in that boy? Please vote and help me. Is it celiac screening, thyroid function test, growth hormone provocation test, or GnRH stimulation test? Where is the correct answer? A type 1 diabetic child who's gaining weight and not gaining height. Excellent. Thank you very much. Most of you got the correct answer. Definitely it is thyroid function test. Of course, in celiac disease, he will be losing weight, as we said, not gaining weight. We do not do growth hormone provocation. We should assess the thyroid, and there is no pubertal problem to do the GnRH stimulation test. Okay. So we found low T4, high TSH, antibodies positive, and the bone age is delayed. Celiac, of course, it's negative. We just did it to confirm. So this is a case of Hashimoto's thyroiditis. Now, let's fit the pieces of the puzzle of that boy. What is the final diagnosis of this boy? Please fit the pieces together and tell me, what do you think? Please vote. Secondary diabetes, monogenic diabetes, autoimmune polyendocrinopathy type 1, APCAT, or autoimmune polyendocrinopathy type 2. Which one? He has type 1 diabetes, he has hypoparathyroidism, Hashimoto thyroiditis, mucocutaneous candidiasis, all together. What is the diagnosis? Thank you very much. Yes, more than 86% got the correct answer. This is autoimmune polyendocrinopathy type 1. Of course, it's not secondary. He doesn't have any other chronic illness or drugs. It's not monogenic at all. It doesn't fit with criteria that we said. It's not type 2 autoimmune polyendocrinopathy because hypoparathyroidism and mucocutaneous candidiasis are characteristic of type 1. You will not find this in type 2. So this is APCAD. Hypoparathyroidism, mucocutaneous candidiasis, and ectodermal dysplasia. And here there is an monogenic autoimmune disorders, including diabetes and thyroid disease. And this is what we call monogenic autoimmunity. So the conclusions here are diabetes could present as a part of autoimmune polyendocrinopathy type 1 or 2. In APCAD, autoimmunities could evolve with time, and therefore you should screen for other autoimmunities each time you see the patient. Every year, for example, screen for other abnormalities. Hypoparathyroidism, mucocutaneous candidiasis, ectodermal dysplasia are the hallmarks of APCAD. This is the basic triad, but could be associated with other things to occur. So, the last case is this nice boy, 6-year-old boy. He was diagnosed as nephrotic syndrome. He took a very large dose of prednisolone. He's not obese. He has a negative family history of diabetes. Now, 5 years later, after the cortisone, he developed secondary nocturnal enuresis. His random blood sugar is very high. His A1C is 7.7. The C-peptide is low normal. He started on insulin 0.4 unit per kg per day, and autoantibodies were not yet done at that time, and the results were not available. Now, what is the most probable diagnosis of this boy? Please vote with me. Is it type 1 diabetes coming on the way, or secondary diabetes due to the very large dose of steroids that he took? Or it could be type 1 or secondary, both are correct, or is it monogenic diabetes? What do you think? Please help me. Most of you got the answer of secondary diabetes. Most of you said it is secondary. Yes, it's clear that it could be secondary, but let me tell you that it could be type 1 as well. Remember, we said that type 1 is the most common cause of diabetes. It could be a coincidence. It's type 1 until proved otherwise, and the follow-up will show. Now, let's see when we followed up the boy, what happened with this boy. Nephrotic resolved. He is off steroids for 5 years. And he couldn't be weaned from the insulin. He still needs insulin, more than 1 unit per kg per day. And the A1C is going high. He's not compliant, 10.8. He had 2 admissions with DKA. Oh, this is not the attitude of just steroid-induced diabetes. It showed itself by time. Is it type 1 diabetes or secondary diabetes due to steroid? Let me ask you again. Please remember that the association of type 1 diabetes and nephrotic could have various possibilities. It could be a chance association. Both are autoimmune disease that could coexist together, could be a common environmental trigger, could be started by steroids. So all possibilities here are available. Yes, it's clear that the boy took a very large dose of steroid, but still the possibility of type 1 diabetes is there, being an autoimmune disease. My message here is that steroid and hyperglycemia is not always secondary diabetes. Again, exclude other types of diabetes. And finally, I think that all diabetic children, whatever the type, face a lot of challenges, the cases and their families. We need to help them in facing these challenges. And the summary is that type 1 diabetes is the most common type of diabetes in children. Definitely yes, but not all children with diabetes have type 1. Exclude type 2 and think of MODY and neonatal diabetes. The knowledge of diabetes type can influence the management, as you've seen. Some types of diabetes, not commonly, but there are types that could respond on oral sulfonylurea. So sometimes it's important to know the type of diabetes to decide the treatment. If you are not sure, treat with insulin. This is the golden rule. But I think whatever the type, it's important to give a lot of motivation to the children and their families. The children and their families are really frustrated. They need our psychological support, not just writing prescription of insulin and referring them to a dietitian. We need to tell them, yes, you can. you can cope with your diabetes, and you can live as normal as possible, to see the happy faces of those children and their families. And finally, let me show you some nice photos painted by type 1 diabetic children when there was a competition done in Ramadan by Arab Society of Pediatric Endocrinology. We asked them to write down what they feel. One of them wrote, put the kids nicely, of diabetes, and wrote, diabetes is not our fault. They are not happy with the diabetes. Another child drew this monster, killing them and executing them. You will be executed for no reason because you are diabetic. This is the negative part of the story. But the nice side and the bright side of the story is this Egyptian 10-year-old boy with type 1 diabetes who wrote, hello diabetes, will you be my friend? He understands his disease. He can cope with it very well. And what he wrote is that diabetes is like a friend. If you treat him bad, he will treat you bad. But if you treat him good, he will treat you good. So this is the concept that we need to transfer to diabetic children and their families. Thank you very much for your attention. I'm so happy to take your questions. Thank you.
شكرا جزيلا دكتورة رشا على المحاضرة الممتعة الجميلة. Really it was outstanding and informative and حضرتك كفيتي ووفيتي and beyond. عندنا أسئلة كتيرة والإنجيجمنت كان جامد جدا من الحضور، فممكن ناخد بس كام سؤال قبل second speaker. في سؤال بيقول many cases of type 1 diabetes require very high doses of insulin. Any suggestion for such cases? Those with type 1 requiring
ايوه في طبعا اول حاجه we need to make sure ان البيشنتس دول compliant، لان ساعات كتيره قوي العيانين بيفبركوا نتائج ويجوا يورونا انا مش عارف انا كده ليه، انا باخد علاجي كويس قوي، انا ما بعملش حاجه غلط، ويطلع مثلا لو ادوليسنت بيلخبط في الاكل او بيحقنوا نفسهم دوزز كده عشوائيه، او ان البيرنت اعتبروا ان ده كبر خلاص وياخد باله على نفسه، فلازم نفتش. الحاجه الثانيه اللايبوديستروفي، ممكن يكون بيحقن في حته فيها لايبواتروفي او لايبوديستروفي ما بتبقاش ابزوربد كويس، والانسولين بيخرج مره واحده، فاوقات يبقى عالي قوي واوقات يبقى واطي قوي، فاحنا هنتشيك الانجكشن سايت، هنعمل تشيكنج للدوز، نتاكد ان هو مش اوبيس او ما عندوش سورس اوف انسولين ريزيستنس او حاجه ثانيه قد تكون other predisposing factor.
في سؤال من الدكتور خالد بيقول how to manage secondary diabetes.
secondary diabetes entity واسعه جدا، يعني يدخل فيها الثلاسيميا، يدخل فيها السيكل، يدخل فيها الناس اللي على كيموثيرابي، ويدخل فيها الناس اللي هم خدوا ستيرويدز، وده اشهر سبب الحقيقه في السكندري دايابيتس. هي القصه كلها ان احنا هنعتبر انه سكندري دايابيتس الا لو ظهر شيء اخر زي تايب 1 زي ما حصل في الولد اللي انا وريته لكم في الكيس. هم بيستجيبوا على فيري لو دوز انسولين، ما بتبقاش عاليه يعني زي بتوع التايب 1، وبنفضل نعمل فولو اب للبلاد شوجر ونعمل ويننج للستيرويدز بالتدريج لغايه ما نوصل لمرحله ان خلاص الستيرويدز اتوقفت، وننتظر منه انه ان شاء الله هيرجع كويس لغايه ما نوقف الانسولين خالص. بس طبعا زي ما قلت nothing is absolute، يعني ممكن يطلع فعلا بعد كده permanent diabetes ويكمل على انسولين، بس هي البريليمينري ان احنا بنبدا بانسولين يعني مثلا نص يونت بير كيجي بير داي، ونعمل مونيتورنج للبلاد شوجر، والكي بوينت هتبقى تريتمنت اوف ذا كوز، يعني لو هي ستيرويد انديوس هيتحسن لو وقفنا الستيرويد، لو هي مثلا كيموثيرابي هيتحسن لو كيموثيرابي راح، وهكذا يعني. لو هي تايب 1 طبعا خلاص هو كده.
دكتور وليد بيسأل what's the indication to change from Lantus to Tresiba in spite of being stable on Lantus؟ دي حاجة
تمام. بتقولي حاجة دعاء ولا بس هو ده السؤال؟
لا ده السؤال.
تمام. طيب لو العيان كنترولد على اللانتوس خليني على اللانتوس، مفيش indication to change خالص. تمام؟ انما بعض الاطفال ما بيستجيبوش على اللانتوس لانه احيانا ما بيقدرش تكفر ال 24 ساعه كلهم، يعني الاطفال اللي وزنهم فوق 20 كيلو عاده هيحتاجوا، اللي وزنهم اقل من 20 كيلو الصغيرين يعني الفيري يونج، هيحتاجوا يقسموا الدوز على مرتين. يعني لما يبقى عندي طفل مثلا عنده 3 سنين غالبا وزنه صغير مش هيقدر اللانتوس تكفر ال 24 ساعه، فهحتاج اديله جرعتين لانتوس، في حين ان التريسيبا هيقدر تكفر الديفكت ده. يعني اقدر اقول كده بسهوله الشخص اللي هيحتاج انه يقسم جرعتين لانتوس او جرعتين ليفيمير بدل ما تبقى شكه واحده، لو عايزاها تبقى شكه واحده هخليها تريسيبا، لان التريسيبا بيشتغل حوالي 42 ساعه، فما عندوش حكايه انه هيضعف بالتدريج على قبل ال 24 ساعه. الناس دول دايما شكوتهم بتكون قبل العشاء بيبتدي يعلى، اللي هو قبل ما يكون قرب ياخد جرعه اللانتوس اللي قبل النوم بيبتدي يضعف اللانتوس. انما الحقيقه لو هو مستجيب عليه خلاص مش محتاج اقلبه، مفيش انديكيشن ان انا اغير الانسولين لو هو ريسبوندينج والاي 1 سي كويس.
تمام. استكمالا لكلام حضرتك دكتور امجد بيسال deglutic insulin action is 42 hours given every 24 hours. Why no cumulative effect of hypoglycemia there؟ يعني ليه ما فيش hypoglycemia؟
لان هو الحقيقه البيك بتاعه يعني nearly there is no peak. ده السبب ان البيك مش هقول 100% بس هو البيك بتاعه ما بيعملش بيكس عاليه، ومع ذلك لا هو في هايبوغلايسيميا بتحصل ساعات، مش زيرو يعني، في هايبوغلايسيميا بتحصل ساعات، يعني مش ابسوليوت، ما اقدرش اقول ان هو خلاص كده زيرو هايبوغلايسيميا، بس كل ما البيك هيبقى اقل هنقلل الانسيدنس اوف هايبوغلايسيميا. بس هو طبعا once per day وبيشتغل 42 hours.
دكتورة سالي بتقول why screening celiac yearly and not once at diagnosis؟
انا اصلا السيلياك مش هتوقعه ان انا اول ما هشخص الدايابيتس هلاقيه على طول، يعني هيبان with time، وممكن ان انا في اول فيزيت اطلب السيلياك ديزيز وبعد كده بطلبه كل سنه. احيانا هطلبه قبل السنه لو ظهر لي حاجه سجستيف، بمعنى ان العيان مثلا مش بيطول كويس، العيان عمال يخس، العيان عنده انيميا ملهاش سبب معين اقدر افسره، عنده هايبوغلايسيميا مش لاقيه لها سبب، ساعتها انا حتى مش هستنى سنه، انا هعمل سكريننج للسيلياك at that time at onset وبعدين كل سنه واف indicated.
تمام دكتورة رشا. دكتورة أمنية مجدي بتشكر حضرتك جدا على المحاضرة وبتسأل
ازيك يا أمنية؟
كالعادة. وبتسأل an interesting question. A 10 years old boy with a prolonged honeymoon period over 1 year and he has positive anti-GAD antibodies. He has a positive family history of transient hyperglycemia in his mother, resolved without treatment. Does the presence of antibodies exclude MODY?
No. Very nice question. No. احنا زي ما قلنا في اوفرلاب ما بين انواع الدايابيتس المختلفه، ان ساعات بيحصل حاجه يبقى ويك بوزيتيف احنا الحقيقه ما بنصدق نمسك فيها ونقول تايب 1، وبصراحه يعني هو تايب 1 هو الموست كومن ما نقولش لا، بس لما تبقى الحاله برولونجد قوي وماشيه حلو قوي زياده عن اللزوم مش زي التايب 1 ممكن ساعتها نشك في مودي، خصوصا لو في فاميلي هيستوري زي ما امنيه بتقول، لانه سترونجلي جينيتك طبعا.
تمام دكتورة رشا. في سؤال من دكتور عمرو بيشكر حضرتك الأول، بيقول لحضرتك how can I differentiate the cause of hypoglycemia when I suspect that the case is iatrogenic insulin administration rather than organic؟
يعني بالسيبت اولا لو انا عندي عيان بيجي له لو هو مش دايابيتك، لو عندك عيان هو قصده هايبوغلايسيميك خالص ولا دايابيتك وبيجي له هايبوغلايسيميا؟
هو اكيد في سياق الكلام هو مش محدد، بس اكيد دايابيتك بيشنت يعني
اوكي. لو كده يعني هيبقى اولا بالهيستوري بيبان ان الفاميلي دي كوربتد او فيها مشكله، وبرده السي بيبتايد هيبقى، بس طبعا مش هقدر احددها قوي 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 بالسي بيبتايد، واي شود اكسكلود اذر كوزز، يعني لازم اتاكد ما فيش ثايرويد ما فيش سيلياك، وبعدين بعد كل دول ابتدي اسسبكت، انما ما فيش تيست بعينه كده في الدايابيتك هعرفه اقول ده سبب كده، انما في الناس الثانيه اللي هي مش دايابيتك وانا شاكه في مانشاوزن هقدر بكريتيكال سامبل هلاقي السي بيبتايد سبريست، اسهل في الناس اللي مش دايابيتك.
في سؤال عن المينيمال ايج فور انسولين ديجليتيك، المينيمال ايج تو جيف انسولين.
هو خلاص ابروفد من سنه دلوقتي recently.
تمام. سؤال من دكتور احمد why in MODY we use sulfonylurea despite that metformin is the first line in the guidelines؟
لا هو في انواع من المودي بتستجيب جدا على السلفونايلوريا، يعني هو المودي مش واحد، المودي انواع كتير، فهو النوع اللي هو المودي 3 بالتحديد بيستجيب جدا على السلفونايلوريا، انما هي مفيش حاجه معممه للكل، هي في various genetic mutations وبتختلف الى درجه ان في ما بيحتاجوش علاج اصلا زي المودي 2 الحاله اللي انا وريتها اللي هي asymptomatic hyperglycemia وبالصدفه ومش محتاج علاج. المودي 3 هو كده الجينيتك ميوتيشن ده بيستجيب على السلفونايلوريا، يعني هي الحكايه variable، مش كل المودي نفس العلاج يعني.
تمام. دكتور مصطفى داوود بيشكر حضرتك على الانترستنج برزنتيشن وبيقول التارجت بلاد شوجر ان يونيتال دايابيتس، وات از يور تارجت؟
طبعا انا مش هتعامل مع النيونيتال دايابيتس زي التشايلد العادي، انا هدفي في النيونيتال دايابيتس ما يحصلوش هايبوغلايسيميا عشان ما يحصلش برين انسلت، يعني احنا بنبقى عايزينه كده في اواخر الميات واب تو 200 ماشي، انما انا مش عايزاه مثلا يبقى 100، مش عايزاه يبقى 90، مش عايزاه يبقى الارقام الخفيفه الكلام ده، لا، لان انا بخاف من الهايبوغلايسيميا. فاحنا لو انا هعمل كومبرومايز اخليه عالي سنه يعني 100 حاجه و80 200 210، ولا اخليه ناحيه ال60 وال70؟ لا، اخليه عالي سنه، ده في النيونيتال، ومش بس كده في الصغيرين اللي هم 2 و3 والسن الصغير، عشان الهايبوغلايسيميا بتعمل برين افكشن.
تمام دكتور رشا. ناخد سؤال كمان بيسأل دكتور مصطفى برضو الفولو اب in thalassemia diabetic patient does hemoglobin A1C is reliable to follow them in the control of these diabetics especially that they are receiving frequent blood transfusion.
بصراحه ما بيبقاش ريلايبل قوي. عنده حق يعني الفولو اب في الثلاسيميك از فيري ديفيكلت فيري ديفيكلت الصراحه يعني، وهم اساسا مش كومبلاينت وعندهم مشاكل كتير، مش هيبقى اكيوريت قوي، بس اتس ا فورم يعني، بس هو مش هيبقى اكيوريت قوي، هيبقى ديسيفنج طبعا. الحاجه المهمه قوي هي الفيرتين، ان احنا كلما استطعنا ان احنا نخلي الفيرتين مش عالي قوي وان هم بياخدوا كيليشن ثيرابي كويس، هنقدر نحافظ على الاندوكراينوباثيز كلها، على البيتويتري وعلى البنكرياس وعلى الثيرويد والباراثيرويد. الفيرتين لما بيبقى اراوند 1000 غالبا مش هيبقى فيه الديبوزيشن العالي اللي هو بيبوظ الاندوكراين جلاندز، ف it's very important to follow up الفيرتين كمان. وطبعا الاي 1 سي مش هيبقى as accurate as الشخص العادي اللي مش ثلاسيميك.
ممكن نستخدم حاجه ثانيه زي البروبتوزامين مثلا
مثلا
ممكن to be used. طيب دكتوره زينب بتسال can type 1 be associated with insulin resistance and if it happened what is the treatment؟
yes احيانا فعلا احيانا تايب 1 بيبقى برضه associated بانسولين ريزيستنس، خصوصا لو حد اوبيس. يعني لو تايب 1 وديفلوبد اوبيسيتي بيبقى فيه some sort of insulin resistance، وبنعرفها ان احنا عمالين نعلي الدوزز وبرضه مش بيتحسن البلاد شوجر كويس. في الحاله دي ممكن تو اد ميتفورمين مع المين ميل، يعني مثلا ممكن ياخد دوز اوف ميتفورمين مع الغداء بلس الانسولين اللي هو ماشي عليه على طول. بس مش هعمم هذا الكلام، ما اقدرش اقول ان ده بروتوكول ماشيين عليه لكل الناس. التايب 1 طبعا علاجهم هو الانسولين والدايت والإديوكيشن، انما لو حد اوبيس وباين عليه some sort of resistance you can combine الميتفورمين مع الانسولين ثيرابي خصوصا في المين ميلز.
تمام دكتور رشا. انا بستأذن حضرتك لو نأجل الأسئلة شوية للآخر وننتقل للسكند سبيكر بعد إذن حضرتك عشان الوقت بس. فأنا أحب دلوقتي نقدم our second speaker. I'm extremely delighted to introduce the second star in this night, which is Professor Basma Abdelmuaz. Professor Basma is the Professor of Pediatrics and the Head of Pediatric Endocrinology and Diabetes Unit in Minya University. She is a member of the Egyptian Society of Pediatric Endocrinology and Diabetes, (ASPED), and she's a member of the International Society of Pediatric Endocrine and Adolescent Diabetes, (ISPED), and she is a member also of the Arab Society for Pediatric Endocrinology and Diabetes, (ASPED). Today she will speak to us about the most life-threatening complication, acute complication of type 1 diabetes. Of course, it's diabetic ketoacidosis and how to make it easy. Prof. Basma, the screen is yours. اتفضلي.
أنا متشكرة قوي يا دكتور دعاء على التقديمة الحلوة دي، وفي الحقيقة يسعدني ويشرفني إن أنا أكون مع حضراتكم النهاردة. وفي الحقيقة هي مهمة صعبة ومستحيلة إن أنا أبقى بعد دكتورة رشا طريف كسبيكر يعني، فربنا يقدرنا على هذه المهمة الصعبة. في الحقيقة دكتور رشا لما اتفقنا على الويبينار دوا، أنا فكرت إن أنا أتكلم على diabetic ketoacidosis how to make it easy. وافتكرت زمان كده من كام سنة صغيرين مش سنين كتيرة، لما كنت في الاي ار وبتواجهني حالة DKA، كان بينتابني إحساس كيفن في فيلم هوم ألون، وبقول واو a case of DKA it will be a terrible night. So the main purpose of this lecture to give the idea about the proper management of DKA, to have good outcome and to have this smile, not then the panic attack when we face a case of DKA. As we know, DKA is a serious life-threatening acute major complication of diabetes mellitus. First case was described in 1996, and until the discovery of insulin in 1920, it was fatal. DKA needs early recognition and good manipulation to have good results. The prognosis of DKA is worse in the extremes of age, with a mortality of 5 to 10%. With the new advances of therapy, DKA mortality decreased to less than 2%. But the main problem in our hospital that most cases were referred to our hospital, where we are at tertiary care centers, and they have a very bad prognosis because their bad manipulation of them. About the diagnosis of DKA, it consists of a triad of hyperglycemia with blood glucose more than 200 milligram per deciliter, pH below 7.3, bicarb below 15 millimole per liter, and ketosis where elevated serum and urine ketones, and the serum ketones more than 3 milliequivalent per liter. SPADE 218 classified DKA severity into 3 categories. The milder one where the pH below 7.3 and bicarb below 15 millimole per liter and the patient is alert. Moderate DKA where the pH is less than 7.2 and the bicarb below 10 millimole per liter and the patient is drowsy. And finally, the severe form of DKA where the pH below 7.1 and bicarb below 5 millimole per liter and the patient in coma. Does every case of DKA must have the 3 components of hyperglycemia, ketosis, and acidosis? The answer is no, because there is a category of euglycemic DKA where the patient becomes with increased anion gap, ketonemia or ketonuria, and the blood glucose level less than 200 milligram per deciliter, and there are many causes of euglycemic DKA reported in the literature, which may be low caloric intake, fasting, or starvation. And this is a mother problem, where the mother know the baby had type 1 diabetes, become anxious and become irritable, and decrease the caloric intake of the patient, and maybe fasting or starvation, and the patient come with DKA. Also, partially treated children may become with euglycemic DKA, enhanced urinary excretion of the glucose by the counter-current hormones, pregnancy, pancreatitis, cocaine intoxication, prolonged vomiting or diarrhea, and insulin pump use. What about the hyperglycemic hyperosmolar states, which was before known as hyperosmolar non-ketotic hyperglycemia? As we see in hyperglycemic hyperosmolar status, the glucose level was very high, up to 1,200 milligram per deciliter, and the sodium becomes higher, the potassium may be normal, the osmolarity is higher than those found in DKA, but the plasma ketones may be not present, or if they present in low percentage. About the serum bicarb, it may be normal or slightly lower. The arterial pH and bicarb and the anion gap may be normal, not like the DKA, and the treatment of hyperosmolar hyperglycemic state is different than the DKA as regard the lab values in it. What about the pathophysiology of DKA? As we know, the DKA pathology is the decrease of insulin deficiency, and increase of the countercurrent hormones contribute to the following: increase in hepatic glucose production with decreased glucose peripheral utilization. This leads to hyperglycemia with osmotic diuresis and volume depletion. On the other side, the adipose tissue liberate free fatty acids, and the liver increase ketogenesis. Both of them lead to ketoacidosis, decrease alkali reserve, and metabolic acidosis. So the final result is fluid and electrolyte depletion with renal hypoperfusion. What about the factors which may often associated with development of DKA? Because it's very important during dealing with the case of DKA, know what is the factor precipitating this event. Infections constitute about 1/3 of the causes of precipitating DKA. Unfortunately, COVID-19 becomes evident in many cases of DKA. 1 hour ago, my colleague called me about a case of DKA in our unit, and we proved that he had COVID-19. The other cause is omission or inadequate insulin, 30%. Initial presentation of diabetes mellitus, 20%. And I think after the knowledge and the announcement of the type 1 diabetes, many patients know the diabetes diagnosis before entrance into the DKA. Medical, surgical, stress, emotions constitute about 10%, and unfortunately, many cases going for tonsillectomy maybe had post-operative DKA because there is no diagnosis of the diabetes before the operation. Please, our colleagues in different departments must search for diabetes, especially those who enter operative. Unknown cause, 5%, drugs like Dr. Rasha said, steroid or thiazide, and pregnancy. When we face a case, certain possibilities. First, skipping dose, and especially in adolescent, eating disorder, also especially in girls, psychiatric problem, mainly behavioral disorders, and we have a research work about psychiatric problem among diabetic patients, and they constitute a very high prevalence. And finally, drug abuse. Any patient with recurrent episodes of DKA, we must search for these 4 reasons. What about the intervention? We must have short history taking, examination, baseline investigations, treatment monitoring, and transition to outpatient management, and we will give a spotlight about everyone. About the history, it's very important to search about the symptoms of hyperglycemia, abdominal pain, vomiting, cosmal respiration. We must search for the history of excessive thirst, urination, and secondary enuresis, sudden loss of weight, complaints of stomach pains or nausea. Also, we search for the deep, heavy breathing, frothy smelling smell, or drowsiness. About the examination, we must insist on the CNS status, look for the degree of dehydration, and this is very important for the calculation of the fluid which will be taken by the patient. Assess the hemodynamic status, search for hypotension and shock, acidotic breathing, look for signs of hidden infections. We must accurate with the patient, and it's better to have the weight and the height to calculate the body surface area. Concerning dehydration, which is present in many cases of DKA, the appearance of the patient, the skin turgor, the mucous membrane, the capillary filling time, which is normally more than less than 2 seconds, the blood pressure, pulse, and the eyes, and the more severity of the dehydration, the lethargic, the patient, the oliguric, the capillary, delayed capillary filling, dry mouth, and so on. The initial lab evaluation includes plasma levels of blood glucose and ketones if it is possible. Venous blood gas, please don't waste time for arterial blood gas sampling. It's very important to have the pH and the bicarb level, so it is not, unless the oxygen saturation of the patient is low, we can have venous blood gases sampling, not arterial blood gas sampling. Also electrolytes, including the sodium, potassium, calcium, magnesium, chloride, and phosphate, urine analysis and urine culture, renal function test, and hemoglobin A1C percent if it is possible, especially in newly diagnosed cases. ECG is very, very important in any case of DKA. And calculate the serum osmolarity and the anion gap. There are certain equations which are very important during dealing with DKA. The first was anion gap, which equal sodium minus bicarb plus chloride. Normally it is 12 plus or minus 2 millimole per liter. In DKA, it may reach to 20 to 30 millimole. If it is higher, we must thinking of the lactic acidosis. The other equation is effective osmolarity. It equal 2 by sodium by milli equivalent per liter plus glucose milligram per deciliter divided by 18. And the effective osmolarity can be calculated by millimole, not milli equivalent and milligram, by this equation. What are the treatment goals? The treatment goals can be summarized
دكتورة بسمة، دكتورة بسمة
انترنت ولا ايه؟ انا مش
انت
عارفه.
سامعاني يا دكتورة بسمة؟
هو الصوره فروزن، مش عارفه.
دكتورة بسمة. طب الدكتورة أمينة معانا؟ دكتورة أمينة، دكتورة أمينة،
يا فندم.
دكتورة أمينة ازي حضرتك؟
الحمد لله يا فندم.
الله يخليك يا فندم، ربنا يحفظك. معلش حضرتك، انا في المقدمه خالص كنت حضرتك هتقولي كلمه وانا والله ما اقصد يعني ايه، يمكن اتكلمت مع الدكتوره دعاء على طول، فعذرا يعني انا بعتذر لحضرتك عن الموضوع ده.
لا يا فندم، لا لا
معلش،
هي كانت.
فربنا يبارك لك. انا هستاذنك في يعني في مشكله عند الدكتوره بسمه، فهستاذن حضرتك يعني ايه، ممكن حضرتك سيادتك تبداي وبعد كده الدكتوره بسمه ان شاء الله تبقى تكمل باذن الله، لما تخلصي حضرتك تبقى تكمل الجزء المتبقي من
ان شاء
المحاضره
الله،
بتاعتنا.
ان شاء الله.
تمام تمام. يسعدنا دلوقتي ان احنا نكمل مع دكتوره امينه استاذتنا الجميله الغاليه. اهلا بحضرتك، نجمتنا الثالثه في الليله الجميله دي. اهلا بحضرتك دكتوره امينه عبد الوهاب، Professor of Pediatric and Pediatric Endocrinology and Diabetes, Swiss Canal University. She's a member of the ESPE, the European Society of Pediatric Endocrinology, and she's the member of the Egyptian University Promotion Committee for Assistant Professor، ودي حاجة مهمة جدا جدا بالنسبة لنا. وهتكلمنا عن موضوع مهم جدا جدا، وهو ال Sick Day Management in Type 1 Diabetes. A closer look. فتعالوا نقرب واحدة واحدة كده علشان ناخد closer look to the Sick Day Management of Type 1 Diabetes. دكتورة أمينة، the screen is yours، وتفضلي حضرتك أمتعينا بمحاضرتك الجميلة. تفضلي. شير سكرين.
دكتورة أمينة، السهم الأخضر اللي فوق ده حضرتك شفتيه؟
ايوه يا فندم، انا.
اتفضلي براحتك.
حاضر.
تمام تمام.
الله ينور.
اعملي حضرتك بقى السلايد شو.
بس كده كده واضح؟
تمام يا دكتورة أمينة، اتفضلي حضرتك. اتفضلي. ممتاز.
طبعا في البداية أنا يعني سعيدة جدا بوجودي من المجموعة الجميلة دي، الدكتورة رشا، والحقيقة يعني سعيدة جدا بوجودي مع الدكتورة دعاء، وبشكر الدكتور محمد على تعبه دايما وهو اللي بينظم لنا كل حاجة. وطبعا أنا يعني الموضوع ده اخترته لأن السيك داي مانجمنت مهم جدا جدا في تايب 1 دايابيتس. عايزين نعرف ايه الفرق ما بين الاطفال اللي بياخدوا انسولين في تايب 1 دايابيتس during sick days، والاطفال اللي هم هيروحوا سيرجري، وكمان الاطفال اللي على انسولين بامب. ايه الحاجات اللي انا بديها لهم يعني في الانسولين عشان اظبط كل حاجه، ويبقى ما يدخلوش مني في DKA او هايبوغلايسيميا. فعايزه اعرف ايه هو السيك داي مانجمنت. السيك داي مانجمنت refers to the changes necessary if there is likelihood that the child intake will differ from normal, or there is intercurrent infection that brings a change in blood glucose due to acute illness or any illness. The sick days include الانفكشنز، الميديكال emergencies، الالكتيف and emergency surgeries، الميديكيشن side effects، any interruption of insulin. بالنسبة للإلنس كان affect البلاد جلوكوز variably. ممكن يبقى ما فيش أي influence على إطلاقا في الحالات الفيرال انفكشنز اللي هي بتبقى very mild with few symptoms. ممكن البلاد جلوكوز results in blood glucose يبقى low لو كانت associated with diarrhea و decrease في الانتيك. ممكن results in high blood glucose if associated with fever, and this can progress in sometimes to DKA. عندنا during illness there is with fever there is increase في counter regulatory hormones و increase في peripheral insulin resistance، وفي نفس الوقت بيبقى فيه decrease في الاورال carbohydrate intake. بينتج عنها ان يبقى عندنا hypoglycemia او hyperglycemia او hyperglycemia with ketosis او ketosis independent of hyperglycemia. عايزين نشوف السيك داي رولز او السيك داي برنسبلز اللي هي لازم نتبعها في كل الاطفال بتوع type 1 diabetes during disease او during sick days. في عندنا sick day guidelines including insulin dose adjustment, more frequent monitoring of blood glucose and ketones, don't stop insulin، ودي نحط تحتيها 10 خطوط، don't stop insulin at all، monitor hydration، treat any underlying precipitating illness. يبقى عايزين نشوف بقى بالتفصيل شويه الانفورميشن at diagnosis اللي بتاع السيك داي guidelines should be simple, focusing on frequent monitoring of blood glucose and ketones, don't stop insulin during illness, if you find any problem just call the healthcare team for any advice. ده بيقلل المشاكل يعني النص. sick day management education should be repeated and extended. في الأول بندي معلومات بسيطة، بعد كده بنزود شوية عشان يبقى استيعابهم يعني يبتدي يكون أفضل. Information about sick day foods and hydration supplies to maintain hydration و prevent dehydration. المفروض يبقى عندهم sufficient glucose وكيتون monitoring supplies وانسولين. Appropriate advice regarding management of gastroenteritis. Encourage families to immunize their children to decrease the frequency of infection. بالنسبة للمور frequent monitoring احنا عندنا يهمنا الجلوكوز monitoring والكيتون monitoring. بالنسبة للparents والadolescents should keep an eye on glucose trends. The blood glucose should be monitored at least every 3 to 4 hours during sick days. The urine ketones ممكن استبدله لو ما عنديش وسيلة بعمل بيها البلد جلوكوز assessment. لو أنا بعمل جلوكوز monitoring بقدر أعرف illnesses اللي associated with hyperglycemia from those associated with hypoglycemia. في السيك days بدي extra doses of insulin in direct relation to the ongoing blood glucose monitoring. الكيتونز هي معروفة إنها بتبقى produced by the liver from free fatty acids to be utilized as an alternative source of energy in case of insulin deficiency. الكيتونز accumulate because of increased lipolysis, ketogenesis with insulin deficiency و increased counter-regulatory hormones. ممكن بيحصل starvation ketosis لما بيكون في low blood glucose level. monitoring البلاد كيتونز مهم، بيبقى افضل من اليورين كيتونز وان كان هو ما بيبقاش افيلابل كتير وكمان بيبقى expensive. ليه؟ لان هو بيأفويد الاديشنال انسولين ادمنستريشن لما والهايبوغلايسيميا اللي بتحصل لما الدي كي اي بيريزولف، انما لسه بيكون في كيتونوريا. Don't stop insulin at all. Insulin doses are increased or decreased to maintain the blood glucose metabolism. They should never be stopped because of the risk of DKA. Even in the fasting state, insulin is required for basal metabolism. More frequent monitoring of glucose and ketones is required to direct the insulin dosage. ممكن بيحصل عندنا episodes of hyperglycemia وكيتوزس من غير ما يحصل infection. امتى؟ دي لما يكون في restriction of insulin intake او omission of insulin intake، وده بالظبط بيحصل في الادوليسنت جيرلز اللي هم عايزين to lose weight واللي عندهم disordered eating behavior. المفروض ان احنا نتاكد من الانسولين كولد تشين عشان to ensure the potency of insulin. نشوف برضو النمبر اوف انسولين فايلز، نسال البيرنتس عليها لان البيرنتس may undergo dosing because of financial issues. Review the injection site. ممكن الانجكشن يكون في hypertrophic areas، فده هيأثر على الانسولين absorption ويدينا دايما قرايات عاليه وكان progress to DKA. Monitor and maintain hydration. عندنا حاجات كتيره ممكن تؤدي للديهيدريشن في حالات الدايابيتس. ممكن الفيفر نفسها، الهايبرجلايسيميا، الاكسسيف جلوكوجوريا والكيتونوريا، وبتؤدي الاكسسيف فلويد لوس. الليكويدز فور هايدريشن المفروض انها تكون تحتوي على سولت ووتر. التشيكن سوب ده من الحاجات اللي هي في الاسباد 2018 اتكلموا عنها، والهوم ميد ليمونيد واللي هي بتحتوي على both salt وشوجر وفيها good source of water والالكترولايتس. لو البلاد جلوكوز بيقل عن 180 بندي sugar containing fluids to decrease the risk of starvation ketosis. لو عندنا نوزيا وفوميتنج ودياريا لو هي persistent especially في young children بندي intravenous fluids. بالنسبة لل necessary sick day management supplies at home, it should include glucose tablets candies with dried fruits that can provide energy, clean water to provide hydration, sugar or electrolyte containing solutions, easy to digest carbohydrates as crackers, noodles, rice, yogurt. Treat the underlying illness. هو treatment of the underlying illness في الدايابيتكس زي غير الدايابيتكس. النوزيا والفوميتنج اللي موجوده ممكن نلاقيها في حالات الجاستروانترايتس والفود بويزنينج والسيفير هايبوغلايسيميا والانسولين ديفيشنسي leading to diabetic ketoacidosis. كل دول ممكن present with nausea او vomiting، فلازم نعرف السبب عشان نعالج مظبوط. بالنسبه للانسولين دوزنج ريكومنديشن فور 6 days دي مهمه جدا. المفروض ان احنا بنحتاج لاديشنال انسولين، بندي الرابيد اكتنج انسولين او الشورت اكتنج انسولين عشان نقلل البلاد جلوكوز ليفل ونتيرن اوف الكيتوزس وبريفنت الديفلوبمنت اوف كيتواسيدوزس. الدوز بتاعتنا بتعتمد على الليفل اوف هايبرجلايسيميا وبريزنس اوف ابسنس اوف كيتوزس. الاديشنال دوز بنديها as percentage of total سواء الرابيد والشورت اكتنج او اللونج والانترميديت اكتنج انسولين او التوتال اوف بيزل وبولس في حالات البامب ثيرابي. لو عندنا هايبرجلايسيميا without hyperketonemia او small amount of ketonuria بندي supplemental bolus dose of rapid acting insulin or short acting insulin بتبقى حوالي من 5 ل 10% من التوتال ديلي دوز، او بتبقى 0.05 to 0.1 unit per kilo repeated every 2 to 4 hours based on blood glucose وكيتون monitoring. والحقيقه احنا في احيان كتير ما بنبقاش عارفين ايه هي التوتال دوز، فعشان كده لما بنحسبها بالكيلو بودي ويت بتبقى برضه هي بتبقى ليس اكيوريت بس اسهل كتير. لو احنا عندنا هايبرجلايسيميا with hyperketonemia او moderate to large ketonuria بندي bolus of rapid or short acting insulin تبقى 10-20% of the total daily dose أو 0.1 ل 0.2 unit per kilo repeated also every 2 to 4 hours based on frequent blood glucose وكيتون monitoring. الchildren والadolescent even في الهانيمون period برضو بيحتاجوا لسبلمنتال انسولين. في الغالب بتبقى الدوز البسيطه اللي هو 0.05 ل 0.1 يونت بير كيلو وبنأسس الريسبونس. during السيك داي مانجمنت ممكن نزود البيزال انسولين اللي هو بنديه as long acting انسولين او الانترميديت acting انسولين او نزود البيزال ريت في الناس اللي بيستعملوا الانسولين بامب. بالنسبه with pump therapy بيبقى ممكن بندي temporary increase في البيزال ريت up to 50% لغايه ما الكيتونز تبقى improved والبلاد جلوكوز يبقوا improved وبعد كده بنرجع لليوجوال دوز بعد كده. عندنا هنا example a sick child who has blood glucose 250 to 360 milligram per deciliter with blood ketones 1.5 millimole per liter. We give supplemental insulin dose of 10 to 20% of total daily dose, depending on this is hyperglycemia with mild ketonuria, moderate ketonuria. أو بندي 0.1 ل 0.2 unit per kilo. As rapid or short acting insulin نديها كل 2 to 4 hours till blood glucose falls to less than 250 ملغ per deciliter والبلاد كيتونز تقل اقل من 0.06 مليمول per لتر او اليورين كيتونز بتبقى نيجاتيف او سمول. بعد كده تبقى كل حاجه almost رجعت له اوربل نورمال بيبقى any additional doses هتبقى في حدود ال 5 ل 10% of the total daily dose. وبنعمل تشيك للبلاد جلوكوز والكيتونز frequently to avoid any recurrence or any progression. بالنسبه للانفكشن اللي associated with hypoglycemia زي مثلا الفيرال جاسترونترايتس بيبقى فيها nausea vomiting with or without diarrhea. بيبقى عندنا hypoglycemia. سبب الهايبوغلايسيميا reduced oral intake, altered gastric emptying, malabsorption, rapid gastrointestinal transit time with diarrhea. المفروض ان احنا بندي small doses of sugar containing drinks and also electrolyte containing drinks provided there is appropriate insulin coverage. A simple diet can be reintroduced after a while like yogurt وبنانا ورايس وكراكرز. ناخد بالنا من اليورين اوتبوت والويت every 4 to 6 hours عشان نتاكد من الهايدريشن. بنقلل التوتال ديلي دوز by 20 to 50% during gastrointestinal illness associated with hypoglycemia. بنبتدي ب 20% reduction في البيزال انسولين و 50% reduction في البولس انسولين. ممكن البولس دي نديها بعد ما الطفل ياكل عشان نطمن ان هو خد الاكل ومش هيحصل له هايبوغلايسيميا لو هو ما خدش الوجبه بتاعته. الانفكشن اللي هي بتبقى associated with hypoglycemia بنعمل assessment بتبقى فيها الكيتونز ومعاها hypoglycemia بالدينوت starvation ketosis and need for carbohydrate intake وانسولين. لو الهايبوغلايسيميا استمرت وكان البلاد جلوكوز اقل من 70 ملغ بر ديسيليتر ومعاه نوزيا وفوميتنج، لو احنا عندنا availability of glucagon بندي ميني دوز اوف glucagon. هي الدوز بتاعته بتبقى 0.02 ملغ في الطفل اللي عنده 2 years وبتزيد ب 0.101 لكل year of age. الماكسيمم بتاعنا بيبقى 0.15 ملغ وممكن تبقى repeated every 30 to 60 minutes. If hypoglycemia persists لازم هندي IV fluids. بالنسبه للاطفال اللي هم بيستعملوا الانسولين بامب، البيشنت بالنسبه للانسولين بامب ثيرابي they use rapid or short acting insulin. ممكن الدي كي اي can develop rapidly لو حصل interruption في الانسولين نتيجه اي كينكس او انفكشن او dislodgement في الكاثيتر او during intercurrent infection without the patient being aware of this he can passes into diabetic ketoacidosis. لو البلاد جلوكوز بتاعنا 250 ملغ per deciliter or more لازم نتشيك البلاد كيتونز او اليورين كيتونز، لان البلاد كيتونز بتبقى اكسبنسيف وما بتبقاش افيلبل. نبص لاي بروبلمز في البامب سواء كينكس او disconnected catheter. ندي correction dose by insulin syringe not by the pump based on blood glucose and blood ketone levels. نعمل assessment hourly للبلاد جلوكوز وناخد الطفل اللي عنده هايبرغلايسيميا بياخد low carbohydrate fluids orally. لو البلاد كيتونز بتاعتنا اكتر من 0.6 مليمول بير لتر او اليورين بيبقى بوزيتيف فور كيتونز، بندي اللي هو الدوز اللي هو 6 day bolus insulin by injection with pen اللي هو بتبقى البوستر من 5 ل 10 او من 10 ل 20 رول. بنعمل مانج للبامب سواء بنعمل تشينج للتيوبنج او الكاثيتر، وبنعمل نشوف الكاثيتر انسيرشن سايت لو في اي انفكشن. بندي السيك داي بوستر دوز جايد لاينز with pen or syringe according للبلاد جلوكوز ليفل. لما بنعمل ريستابليشمنت للبامب انفيوجن with the new set بنزود البيزل ريت ل 120 ل 150 according للبلاد جلوكوز ليفل والكيتون ليفلز، وبنديكريز with resolution of hyperglycemia and ketosis. بنعمل hourly monitoring للكيتونز والويت عشان الهيدريشن ستاتس. بياخد هاي كربوهيدرات دايت لو الكيتونز are increased والبلاد جلوكوز بيكون low، او drink extra low carbohydrate fluid if the blood glucose is high with or without elevated ketones. If no improvement after 2 hours, we have to consult the diabetes pump team. لو after 2 hours the blood glucose improved في حاجة اسمها ال unused bolus rule to decide if an additional bolus is used، اللي هو بتعتمد على ان لما بندي rapid acting insulin 30% بيبقى absorbed each hour، فلو احنا يعني شفنا الطفل ده بعد 2 hours يبقى احنا لسه فاضل عندنا 40% of the rapid acting insulin ده اللي هو ال unused insulin، فبنعمل حسابنا في واحنا بندي بالبامب. If blood glucose remains high والكيتون persists وفي nausea or vomiting, the patient needs hospitalization. بعد كده احنا عايزين نعرف المانجمنت of children with diabetes requiring surgery. طبعا لازم يبقوا admitted to the hospital for general anesthesia. Insulin is given even if fasting because of the problem of diabetic ketoacidosis can occur. They need insulin infusion even with fasting to prevent hypoglycemia. بالنسبة للإلكتيف سيرجري بنعمل frequent monitoring للبلاد جلوكوز before meals والسناكس والبيت تايم وتشيك اليورينري كيتونز. اليوجوال evening insulin والبيت تايم snack should be given والكيتونز والسيفير hyperglycemia should be corrected before surgery. بالنسبة للمورنينج surgical operation no solid foods from midnight. omit الانسولين dose. start IV fluids والانسولين at 6 a.m. hourly monitoring of blood glucose و half hourly during surgery. وبعد السيرجري بنعمل hourly monitoring of blood glucose for 4 hours post operatively. نعمل تشيك للكيتونز والهايبر جلايسيميا. الايم بتاعنا ان احنا to maintain البلاد glucose between 100 to 200 milligram per deciliter pre-operative and during the intraoperative period. بالنسبه نكونتينيو الاي في انفيوجن لغايه ما الطفل يتولوريت الاورال انتيك، وده بياخد تقريبا 48 ساعه. بعد كده بنتشينج للسبكوتينيوس انسولين اللي هو سواء شورت او رابيد اكتنج انسولين before the first meal، وبنستوب الانسولين انفيوجن 60 minutes after السبكوتينيوس انفيوجن. نعمل discharge after full recovery وانسولين adjustment. بالنسبه للافترنون اوبريشن بنستارت الاي بي فلويدز والانسولين افتر ذا بريكفاست، وبندي بعد كده كل حاجه زي ما ذكرتها قبل كده. لو في emergency surgery المفروض ان احنا برضه بنعمل ادميشن وبندي nothing per oral، نشيك البودي ويت والالكترولايتس والبلاد جازز والكيتونز والبلاد جلوكوز بري اوبراتيفلي. لو في diabetic ketoacidosis او البلاد جلوكوز elevated والكيتونز elevated طبعا بنبوستبون سيرجري till everything is corrected. لو ما فيش اي ketoacidosis بندي الانترافينوس فلويدز والانسولين زي الالكتيف سيرجري. بالنسبه للانفيوجن جايد للسيرجيكال بروسيدرز بندي التايب اوف فلويد جلوكوز 10% و نورمال سلاين. بندي الانسولين انفيوجن زي الدي كي اي. بنستارت الانفيوجن at a dose of 0.05 unit per kilo per hour. الايم بتاعنا to maintain the blood glucose between 100 and 200 milligram per deciliter. لما بيوصل ل 100 milligram per deciliter هو البلاد جلوكوز we don't stop because of the rebound hyperglycemia. We stop 15 minutes if the blood glucose is 90 milligram per deciliter وننتظر until blood glucose is increased. عايزين نعرف ايه هو الانديكيشنز for hospitalization في السيك داي مانجمنت of the diabetic child. لو في underlying condition is unclear وفي persistent fever او في continued loss of fluid و worsening dehydration و circulatory وفي potential circulatory compromise. لو vomiting is persistent beyond 2 hours particularly for young children لان طبعا احنا بنخاف جدا من dehydration. Parents are unable to keep blood glucose above 70 milligram per deciliter او blood glucose continues to increase despite extra insulin doses. If there is manifestation of starting DKA, fruity breath, odor, increased blood ketones, where despite extra insulin doses. لو الchild بيبقى exhausted وconfused وhyperventilating وhas abdominal pain and change في neurological status وفي mental confusion ممكن يبقى فيه impaired consciousness وseizure to avoid the risk of cerebral edema. لو في comorbid conditions زي مثلا disordered eating behavior اللي ممكن بيحصل احيانا parents and caregivers are exhausted to provide the needed care. عندنا 2 cases. Ahmed is a 3-year-old boy with type 1 diabetes having acute gastroenteritis with vomiting and diarrhea and small ketonuria. He is probably in need of or has uncontrolled hyperglycemia, starvation, ketosis, associated medical disorder requiring close monitoring, or he has to be admitted immediately to the ICU. What do you think? He is 3 years old with type 1 diabetes, having acute gastroenteritis with vomiting and diarrhea and small ketonuria. He probably has uncontrolled hyperglycemia, starvation ketosis. Yes, yeah, most of you, 57%, yes. It's not uncontrolled hyperglycemia because this patient just has acute gastroenteritis. And it is not associated medical disorder because nothing in the problem denotes this. And he should not be admitted to the ICU because it is acute problem and can be managed easily with the IV fluids and insulin. Case 2, Layla is 6 years old child with type 1 diabetes, having blood glucose 350 milligram per deciliter, large ketonuria. She requires supplemental rapid-acting insulin dose, 5 to 10% of total daily dose, 10 to 20% of total daily dose, 20 to 30% of the total, or none of the above. Yes, most of you answered correctly. 86% answered the correct answer. So, what's the take-home message? Frequent monitoring of blood glucose and ketones with timely administration of supplemental insulin can successfully manage sick days and avoid progression to DKA. If possible, continuous glucose monitoring can be used as a supplement to blood glucose monitoring if there is facility. Never stop insulin. Insulin dose needs to be modulated according to the presenting condition. Hypoglycemia and hyperketonemia may occur in the setting of gastrointestinal illness or starvation, requiring administration of insulin along with carbohydrate intake. Maintain hydration is very essential in every child with diabetes. Consider hospitalization with failure of home management to bring conditions back to normal. Thank you very much.
شكرا جزيلا دكتورة أمين على المحاضرة الجميلة دي، فعلا استفدنا منها جدا جدا وعرفنا ازاي how to manage our children in the sick days، وربنا يخليك يا رب. Thank you very much. I don't know about Dr. Basma, is the problem solved or not? Shall we go back to the DKA? I'm not sure.
دكتورة دعاء،
ايوه
دكتورة حضرتك ممكن تكملي أسئلة الدكتورة أمينة وبعدين الدكتورة بسمة تخش بعد أسئلة الدكتورة أمين، لو هتسأليها جزء من الأسئلة كده حضرتك.
تمام يا فندم. هو so far الأسئلة يعني كلها بتتجه نحو الدايابيتس in general.
طيب هي الدكتورة
سؤال بيقول هل ال CGM available؟ يعني هل ال CGM monitoring is available in Egypt؟ ده اللي موجود. احنا ممكن نخلي الأسئلة في نعم اتفضلي يا فندم.
لا ممكن لو هي جنرال نخليها للآخر.
نخلي الأسئلة كلها للآخر. تمام، يعني نخلي الأسئلة للآخر خالص ونشوف لو دكتورة بسمة جاهزة.
دكتورة بسمة، دكتورة بسمة معانا؟ ما شاء الله معانا الدكتور بس بتكونكت.
طب ممتاز.
دكتورة بسمة؟
ايوه
دكتورة بسمة.
السلام عليكم.
عليكم السلام ورحمة الله وبركاته.
رجعت بحمد الله الحمد لله.
اتفضلي ربنا يكرمك.
ويلكم باك.
اتفضلي.
ثانك يو لوت.
اتفضلي حضرتك، متعينا تاني بالديكي ايه، احنا يعني كنا مركزين جامد وفصلنا، فنرجع تاني بقى نانجيج مع حضرتك. اتفضلي يا فندم.
ان شاء الله. شايفين كده يا دكتورة دعاء؟
لا حضرتك تعملي شير سكرين بقى بعد اذنك. شير سكرين.
تمام كده؟
تمام ممتاز، اتفضلي حضرتك.
تمام. I'm so sorry for this interruption because of the internet. I'm so sorry. We stop at the typical body deficit of water and electrolytes. And I told you that how can we imagine the loss of the body of the DKA patient. As regard the water, he lost about 70 milli per kg, sodium from 7 to 10 milli equivalent per kg, chloride about 3 to 5, potassium 3 to 5, phosphate from 5 to 7 milli equivalent per kg, and magnesium 1 to 2, calcium from 1 to 2. There are many guidelines as regard the treatment of DKA, ADA, American Diabetes Association, NICE, and SPADE, and all of them give us a simplified appendix with their figures or tables to enable us to proper deal with a case of DKA. Fortunately, there are Egyptian guidelines for diabetes in children and adolescents. And I think 2 years ago, there is a project about a national guidelines for DKA, which will be widely distributed all over Egypt to have a single evidence-based guidelines for treatment of DKA. What about the supportive measures in case of DKA? We must secure airway and empty stomach, especially if there is a history of fluid intake during the last 2 hours, a second intravenous catheter, a cardiac monitor, and the CVP in shocked patients. We must give oxygen in those with severe circulatory impairment by a high flow nasal cannula. Give antibiotics if we suspect sepsis, especially in those who were febrile or hypothermic. We must collect urine to give an indication about the renal function, and the catheterization may be needed in comatose patients or those who are young and we cannot collect urine. What about the management? The management consists of 4 cornerstones. The first one is rehydration, then insulin therapy, thirdly, electrolyte repletion, and finally, management of the complications and evaluation of therapy and the precipitating factors if possible. Concerning rehydration, it must be early and gradually. Volume. It is very important during DKA management. Why it must be early? To restore the intravascular volume, to reduce the blood glucose level, reduce the counter-regulatory hormones, whether catecholamines or glucagon, and augment the insulin sensitivity. Why it must be gradually over 36 to 48 hours to avoid the iatrogenic fluid overload and the possibility of cerebral edema, which is the commonest cause of mortality of DKA. We must have a monitor by jugular venous pressure, urine output, and we must search for the complications of fluid therapy, which is cerebral edema or hypercaloric acidosis or adult respiratory distress syndrome. What about the fluids? What about the amount of fluid? I see a question from one attendee about the fluids and the type of the fluids and which is the rate of the fluids. The initial fluids is a bolus dose of 10 milli per kilogram of the normal saline over 30 to 60 minutes to have a reperfusion of the body. In case of severe dehydration and shock, it must be 20 milligram per kg quickly and maybe up to 30 milli per kg in a case of shock. While mild to moderate dehydration, we can start deficit and maintenance therapy. Note that the initial intravenous bolus must be subtracted from the total fluid to avoid the overload of the fluids. may need to adjust the type and the rate of the fluid in patients with congestive heart failure or those with renal failure. About the subsequent deficit plus the maintenance fluid, it must be all children will experience a decrease in the vascular volume. When the plasma glucose concentrations fall during the treatment, we must use tables of the pre-calculated volumes based on the weight and the 10% dehydration over 48 hours per hour. And fortunately, the SPADE guidelines 2018 give us this table, which is very simple table, and calculate the amount, whether the deficit and the maintenance therapy, as we see by the milli per 24 hour and the milli per hour as regarding the body weight of our patient. The first 6 hours, it is preferable to have the normal saline, while the next 42 hours, we must have a half normal saline, and there are many studies about the use of whether the full saline or the full strength saline or the half normal saline, and there is no difference between them as regard the occurrence of cerebral edema. So if there is no half normal saline, we can use the normal saline, but we must observe the sodium trend every 2 to 4 hours. Positive sodium trend, we see that increase in the sodium by 2 milli equivalent with every 100 milligram drop of the blood glucose. And if there is negative sodium trend, no increase of the sodium by 2 milli equivalent per liter, we must use the full strength of the saline, not the half normal saline. When we add glucose, we add glucose 5% firstly. When the blood glucose falls to 250 to 300 milligram per deciliter, or the rate of the drop of the blood glucose more than 90 milligram per hour with a ratio 1 to 1. If the descent of the blood glucose is more than 90 milligram per deciliter, we can use 10% glucose, or sometimes we can use 12.5% glucose to keep the insulin infusion. As we said, the insulin infusion is a cornerstone in the treatment of DKA where there is insulin deficiency. What about the oral intake? In severe dehydration with impaired consciousness and acidosis, allow sips of water. But oral fluid should only be given after the clinical improvement with no vomiting to avoid the aspiration of our patient. When good clinical improvement before 48 hours, rehydration calculation and intravenous fluids must be reduced. If there is carbohydrate, it's preferable to give carbohydrate to our patients, and this will this keep the insulin infusion in a suitable rate. What about the insulin therapy? Let us see the action of this magic hormone. I said that insulin is a magic hormone. It has 10 functions, at least 10 functions. As we say, the red one, which denotes the stop of certain process inside the body: gluconeogenesis, glycogenolysis, lipolysis, ketogenesis, and proteolysis. Why? It augments glucose uptake in the muscle and adipose tissue, glycolysis, glycogen synthesis, protein synthesis, and uptake of the ions, especially sodium and phosphate. The first question in this lecture: when you must begin insulin infusion? Please help me to answer this question. When we must begin insulin infusion, at the same time with insulin therapy, or after 30 minutes of infusion, or after 1 to 2 hours of fluid infusion. Please vote. Please vote. Excellent. Excellent. The right answer is after 1 to 2 hours of fluid infusion. As you said, we start after 1 to 2 hours of deficit therapy to have expansion of the circulation and to reduce the blood glucose level. About the dose, we begin with 0.05 to 0.1 unit per kg per hour, and in certain circumstances we can reduce this dose, especially in younger patients. As regards the target reduction, it must be from 35 to 100 milligram per deciliter per hour. When we consider insulin dose or insulin infusion, when the blood glucose not fall by 75 to 100 milligram per deciliter, or serum bicarb not elevated, even in the normal blood glucose level, and we reconsider the presence of lactic acidosis in these circumstances. How to stop? We must begin the subcutaneous insulin infusion or the insulin pump before stoppage of the insulin infusion. The first subcutaneous injection should be given 15 to 30 minutes if the patient used rapid-acting insulin, or 1 to 2 hours with regular insulin before stopping of the insulin infusion. There are circumstances where there is we cannot admit the patient with DKA in the hospital, especially in this period with the pandemic of COVID. So if continuous insulin infusion is not possible and the patient is uncomplicated, can we use subcutaneous rapid-acting insulin analog? Yes, we can use it every hour or 2 hours, and it be safe and be effective as intravenous regular insulin. We begin with initial dose 0.3 unit per kg, followed by 1 hour later with 0.1 unit per kg every hour, or 0.15 to 0.2 units per kg every 2 to 3 hours. If the blood glucose falls to lower than 250 milligram per deciliter before DKA has resolved, reduce the subcutaneous insulin to 0.05 unit per kg per hour to keep the blood glucose around 200 milligram per deciliter until the resolution of DKA. What about the potassium? The potassium is very, very important electrolyte to be put in our mind during dealing with the case of DKA. There are certain questions about potassium when we use potassium supplementation, and what about the dose, and what about the type of potassium which can be used. This is the second question, and please help me to answer this one. When ideally you begin supplementation of potassium? If the serum potassium below 5 milliequivalent per liter, if serum potassium below 3.5 milliequivalent per liter, or after fluid replacement. Please vote. Please vote. Excellent. 50% of you know the right answer. After fluid replacement. We begin potassium supplementation after the initial fluid therapy. Replacement therapy is required regardless of the serum potassium concentration, except if there is renal failure, because maybe in the first presentation or the initial presentation of DKA, the potassium level may be normal, but actually it is low because the cellular potassium is very low and there is escape of the potassium extracellularly due to the presence of hyperglycemia and the osmolarity and the excretion of aldosterone. What about the dose? What about the dose of potassium? As we see, if the serum potassium level more than 5.5, no potassium at all infusion. But if it is from 4.5 to 5.5, we begin with 20 milliequivalent per liter. If the serum level of potassium 3.5 to 4.5, we begin with 30 milliequivalent per liter. If it is from 3.5 to 4, we begin by 40 milliequivalent per liter. And really, we begin with this dose of potassium supplementation, 40 milliequivalent per liter. If we add 40 milliequivalent of potassium to 1 liter of 1/2 isotonic saline, it creates an osmolarity of 234 millismol per liter. But if we add this potassium chloride to isotonic saline, the final osmolarity will be more, up to 388 milliosmol per liter. What about the type of potassium supplementation? It must be 50% potassium phosphate to replace the phosphate loss due to the osmotic diuresis, but not 100 potassium phosphate because of the fear of hypocalcemia. And the other 50% of the potassium must be in the form of potassium chloride, not 100 potassium chloride, because excess chloride may lead to cerebral edema due to hyperchloremia. What about the ECG changes in hypokalemia? It's very important to have cardiac monitoring by ECG in a case of DKA, because it helps us to diagnose hypokalemia or hyperkalemia. In case of hypokalemia, as we see, there is inverted T wave, prominent U wave, prolonged PR interval, and the ST segment is depressed. What about if there is hypokalemia during dealing with a case of DKA? In this condition, we must reduce the insulin dose to reverse this hypokalemia to normal kalemia. Here we can use the ECG to diagnose the severity of hypokalemia. As we see, with different potassium level, the ECG will be different and diagnostic. This is ECG for reminding us about the difference between ECG in cases of normokalemia, in the cases of hypokalemia, and the cases of hyperkalemia. As we see in hypokalemia, this is a prominent U wave and the T wave was shallow, while in hyperkalemia, the T wave will be tall and peaked, and there is wide QRS. So ECG is very important. I put this slide to show how much ECG is very important during monitoring of the case of DKA. What about sodium? Usually glucose above 100 milligram per deciliter, there is an expected decrease of about 1.6 milli equivalent per liter in the measured sodium, with the presentation of pseudo-hyponatremia. And the sodium should be raised 0.5 millimole per liter for each 100 millimole decrease of the glucose. If the corrected sodium more than 150 milli equivalent per liter, we must think of hypernatremic dehydration, and we must use a half normal saline. When sodium become elevated or decreased, we must think of cerebral edema. You must remember that the corrected sodium equation is very important for evaluation of the sodium level, and the equation equal sodium measured plus 2 glucose over 100 over 100. What about the phosphate? Usually at presentation, the serum phosphate may be normal or increased. The total body phosphate is decreased by 1 millimole per kg. And the decrease occurs because after insulin infusion, the phosphate becomes tended to enter the re-enter the cell. So there is decrease of the phosphate. So phosphate is very important to be supplemented, and we give potassium in the form of potassium phosphate. What are the complications of hypophosphatemia? Actually, phosphate enter in the formation of the ATPase, and the ATPase is very important for the muscle contraction. So if there is hypophosphatemia, there may be metabolic encephalopathy, impaired myocardial contractility, respiratory failure, dysphagia, and the ileus, and the hemolysis, and there may be rhabdomyolysis. What about acidosis and the sodium bicarb? And this is a controversy about the sodium bicarbonate use, and many fights in different departments about to give sodium bicarb or not. There are many questions about the acidosis and sodium bicarb. Is it useful to use sodium bicarb? No, acidosis is corrected with fluids and insulin. Why not routine use? Why we shouldn't use sodium bicarb in a case of DKA? Because Bicarb replacement and rapid reversal of acidosis can lead to impair cardiac function, reduce the tissue oxygenation, promote hypokalemia, hypernatremia, hypocalcemia, and paradoxical CNS acidosis. When reconsider use of sodium bicarb, if there is severe acidosis, the pH below 6.9, if there is life-threatening hyperkalemia more than 6 milliequivalent per liter, if there is ECG suggestive of hyperkalemia, it is given in a dose of 1 to 2 millimole per kg over 100. If there is persistent acidosis, low blood pressure, and lactic acidosis, especially if the anion gap is very high, insulin infusion problem, so we must check the insulin infusion set and the infusion pump if it is working or not, and the set itself, sepsis and renal failure. This is a question for you. What about bicarbonate therapy? Can be used in all the following situations except in acidemia, pH below 6.9, bicarb below 5, or in the case of life-threatening hyperkalemia, where the potassium level more than 6 milliequivalent per liter, ECG changes wide QRS and peaked T-wave, in acidemia with brain edema. Which of those is contraindicated to use bicarb therapy? Please answer. Excellent. Use it in cases of acidemia and life-threatening hyperkalemia. What about monitoring of a case of DKA? It is a teamwork. It is a teamwork. It is a teamwork. No one can monitor a case of DKA alone. The physician, the nurse, and the clinical pathologist, and so on. Flow chart, please, flow sheet, hour by hour, maintain the tabulating. I remembered one of the junior staff in our department when I want to check one of the patients. I see that he wrote a lot of data on the sheet about the follow-up of the patient, and I said that, what are you doing? He said that, I remember the data and I wrote them. It's wrong. Flow sheet must be hour by hour, including the clinic, the insulin dose, fluid electrolyte, which administered, and the urine output, and finally the respiratory monitoring. As regard all of these data, we can reconsider the line of treatment. About the assessment guidelines, every hour we must check the blood glucose level. Every 2 to 4 hours we must check the venous blood gas, serum electrolytes, blood urea and creatinine, serum osmolarity, serum ketones, and every void we must search for urine ketones. And I want to mention that ketonuria can be cured before ketonemia. So urine ketones not indication of the resolving of the DKA, but the resolving of the DKA by the resolving of ketonemia, not ketonuria. This is a monitoring sheet, as we see. There are many examples of the simple follow-up charts, and please insist the staff in your department to have a follow-up charts of our patient with DKA. Make sure the anion gap is closing during follow-up. If the anion gap is not closing, we must consider the following: inadequate fluid resuscitation, inadequate insulin dose, malfunction of the insulin infusion, fenestrating underlying problem which has not been addressed. Consider checking the beta hydroxybutyrate lactate levels to exclude the lactic acidosis. Successful progress during monitoring is judged by hemodynamic monitoring, blood and blood pressure, adequate urine output, improved mental status of the patient, monitoring the decrease in the osmolarity, not more than 3 millismol per liter per hour. What about the complications of DKA? What is the goals? What are the goals of knowing the complications of DKA to prevent them? The main goal to know the complications of DKA, not only to treat them, but to prevent the occurrence of them. They are complications of therapy, iatrogenic. We making them. Inadequate rehydration, cerebral edema, pulmonary edema, hypoglycemia, hypercaloremic acidosis, hypokalemia, hypocalcemia, hypomagnesemia, and hypophosphatemia, or other complications related to the event itself, shock, intracranial thrombosis or infarction, and it occurs in hours or days after the DKA, acute tubular necrosis, peripheral edema, adult respiratory distress syndrome, sepsis, rhabdomyolysis, aspiration pneumonia, and pneumothorax. Cerebral edema is the most dangerous complication of DKA, and it may be iatrogenic, as I said. The incidence is 0.5 to 0.9%, and the mortality rate is up to 24%. The risk factors, some of them related to the patient, children below 5 years, so we must carefully monitor the children with, below 5 years, newly onset diabetes mellitus, home, more acidic pH. The severity of DKA may be related to the cerebral edema. And there are certain risk factors related to the treatment: administration of large amount of fluids in other hospital, administration of hypotonic fluids, sodium bicarb. It may be subclinical at the beginning of therapy, and the CSF pressure may be normal in the first. This is the problem. It may be subclinical, not symptomatic. It occurs typically in the first 24 hours, so monitoring during this period is very important. The pathophysiology of cerebral edema is very simple, where the brain conserves water by producing osmoprotective molecule, which is taurine. So the osmolarity becomes disproportionately higher in the brain than other tissues to keep the hydration of it. Sudden fall in the serum osmolarity during rapid rehydration moves fluid across the blood-brain barrier, and the brain becomes not a progression of decay. What about the signs and symptoms of brain edema? Major criteria: altered conscious level, fluctuation of it, sustained heart rate, bradycardia and hypertension, age inappropriate incontinence, and the minor criteria: vomiting, lethargy, headache, diastolic blood pressure more than 90 millimeter mercury, and the age below 5 years. One diagnostic criteria, two major criteria, or one major and two minor criteria are diagnostic for cerebral edema. What about the treatment? Initiate treatment as early as possible. As soon as possible we suspect a case of cerebral edema, we reduce the fluid to 1/3, and the deficit must be on 72 hours rather than 48 hours. Elevate the head to 30 degrees. Give mannitol in a dose of half to 1 gram per kg intravenous over 10 to 15 minutes, and repeat if it is necessary. Hypertonic saline may be used instead of the mannitol in a dose of 5 to 10 milli per kg over 5 to 10 minutes, and may be used, as I said, as alternative to mannitol if it is not present. Intubation, if necessary, can be, but we can postpone, we must postpone it. We use only in respiratory failure. What about the DKA in some special circumstances? I'll choose some circumstances, maybe not all the circumstances we can facing with DKA. The first one is DKA in hemodialysis patient. Unfortunately, many of uncontrolled patients have renal failure and the hemodialysis. The difference between DKA in hemodialysis patient than a patient with DKA without renal affection, those are not severely volumic depleted. So volume expansion is not recommended in them. And also potassium repletion should be less aggressive than those with usual DKA, not renal patients. Hemodialysis will improve the ketoacidosis and replace bicarb and basically fix everything. But it carries the risk of cerebral edema. So please take care of those with hemodialysis. What about those with heart failure? The difference is also those with heart failure may be hypervolemic prior to develop DKA, so the volume expansion is not recommended because it may lead to the cerebral edema. Serial assessment of the volume status is needed with ultrasonography. Standard DKA protocols may not work specifically in those, and we must recommend excessive fluid administration. What about DKA in those on insulin pump? The following approach describes a safe strategy for many of ours hadn't the experience of insulin pump. So if a patient with insulin pump had DKA, we must firstly disconnect the insulin pump and have initial evaluation and resuscitation. Step 2 are exactly the same as a case of DKA. Step 3, restart the pump, but in this time we must change the set, the cartridge, and insert a cannula in a new site, because maybe the improper cannulation the cause of DKA. What about the pitfalls in DKA management? Sometimes we have pitfalls in DKA management. The first one is failure to recognize the problem. Maybe the patient is not diabetic and this is the first presentation of him. So history taking is very important to diagnose newly cases of diabetes. Failure to recognize cerebral edema, failure to recognize hypokalemia. And the other problem, how to react to this situation. Please remember the movie of Home Alone. Kevin, please, you mustn't be panic, and you must be calm to have the proper solution of every problem. We can avoid all this by keep a flow sheet for fluids, insulin, vital signs, lab values, record all intake and output meticulously, ECG monitor for potassium, urinary catheterization, especially in those comatose, check the pupils, please check the pupils and the reaction of the pupils. There are pitfalls during the diagnosis. Not all the acidotic patients are DKA. Acidotic breathing may be present in renal failure, ammonia, hyperammonemia, and hepatic cellular failure, hysterical. Not all the comatose patients are diabetic. We must search for lactic acidosis, hyperosmolar non-ketotic coma, and hypoglycemia. Differential diagnosis of a coma in general, and the differential diagnosis of acute abdomen. What about the pitfalls as regards the lab? What about the hyperglycemia? Hyperglycemia may be due to diabetes mellitus, hyperosmolar hyperglycemic state, impaired glucose tolerance, or stress hyperglycemia, especially in CNS infection. Metabolic acidosis may be present in DKA and lactic acidosis, hyperchloremic acidosis, uromic patients, or drug-induced salicylate. By the way, I remembered one patient come to me, and the patient had acidosis. I check everything, and everything is good. And by taking the history, I found that the child take salicylate, which is belonging to his grandmother, as a sweet, because it is sugary. So history is very, very important. But about the lab, ketonemia may be resulting of ketotic hypoglycemia, alcoholic ketosis, and starvation ketosis. Sometimes there is interventional errors, fluid shift and shock. So insulin, and this is caused by giving insulin without sufficient fluids and use hypertonic glucose solutions. Hyperkalemia may be resulted due to premature potassium administration before insulin has begun to act to allow the potassium to enter the cell. Hypokalemia, failure to administer potassium once levels falling, recurrent ketoacidosis, premature discontinuation. Junior staff in my department, they want to have resolution of DKA very rapidly. And this is very wrong, because this patient have a recurrent ketoacidosis, hypoglycemia by insufficient glucose administration. So total fluid replacement shouldn't exceed 4 liters per square meter per 24 hours. Deficit should be replaced evenly more than 48 hours, as I said. Remember to subtract the quantities given in the first hours. Re-expansion from 24-hour totals, replacement therapy, use the estimate of dehydration based on the physical examination varying from 5 to 10% of the body weight as regards the dehydration. Pitfalls in DKA lab. Sometimes there are lab investigations may be misdiagnosed in DKA, like high white blood cell count. It is not indication for infection, but due to the stress, the bone marrow give more white blood cell. So white blood cell itself is not indication of infection. But if there is the differential count, show that there is neutrophilia, there is a shift to the left, there is toxic granulation, this means that there is infection. Blood urea nitrogen may be elevated with pre-renal azotemia secondary to dehydration, not due to renal impairment. Creatinine. Some assays may across react with ketone bodies, so it may not reflect true renal function. Serum amylase, it is often raised, and when there is abdominal pain, a diagnosis of pancreatitis may mistakenly be made. What are the strategies to prevent diabetic ketoacidosis? This is very important. As a line of treatment of DKA, how to prevent the diabetic ketoacidosis recurrence? First, as Dr. Rasha said, and Dr. Amina said, diabetic education. It's very important to spend some time with the family of the patient. It's very important to inform them about everything, about the hazards of diabetic ketoacidosis. Blood glucose monitoring, home monitoring, it is very important. Sick day management, as Dr. Amina explained, home monitoring of ketones and beta hydroxybutyrate, supplemental short-acting insulin regimen, easily digestible liquid diets when we are sick, as Dr. Amina said, reducing rather than eliminating insulin when the patients are not eating. Sometimes the mother starve the patient to stop insulin, and this is very wrong. Guidelines for when patients should seek medical attention, case monitoring of high-risk patients, special education for patients on the pump management. Lastly, we return again to Home Alone movie. What are the take-home message? And this is the last part of my lecture. DKA is caused by either relative or absolute insulin deficiency. Children and adolescents with DKA should be managed in centers experienced and equipped for its treatment. In some hospitals, there is a portable biochemical analyzer, and this is very important for the venous blood gas electrolyte monitoring. We must remember the letters of ACT RAPID. 8 steps for managing DKA. A, airway breathing and circulation. C, commence fluid resuscitation. T, treat potassium. R, replace insulin. A, acidosis management. P, prevent complications. I, information of the patients. D, discharge. Priority is given to correction of the state of hyperosmolarity and dehydration by fluid, and this is very important. The fluid is very important. Increase the peripheral glucose uptake, improve the glomerular filtration rate, reserve the acidosis, but we must be cautious to avoid overhydration and the entrance of cerebral edema. So good hydration, not overhydration. Insulin therapy is started only after support of the hemodynamics to prevent the latent shock or rehydration, and intravenous insulin bolus is unnecessary at all and may increase the risk of cerebral edema. Please avoid intravenous insulin. Potassium replacement is started even with the normal levels, as it is expected to dramatically drop with insulin therapy, and the severe hypokalemia may lead to respiratory arrest due to muscle dysfunction. There is no evidence that bicarb is either necessary or safe in DKA. And I mentioned the indications of bicarb administration. Rapid correction of acidosis with bicarb causes hypokalemia, and this is very dangerous. Please check the presence of mannitol or hypertonic saline at the bedside of a case of DKA, and should be begun in a case of profound neurological symptoms when we suspect a case of cerebral edema. I am believed that all cases of recurrent DKA are preventable, and this depends on you. This is the summary of management of DKA, and I finally I wish that I can light the load of dealing with DKA and make it more simpler. make them more easy. And I finally end by a quote by Will Rogers, who stated that a man only learns in two ways, one by reading and the other by association with smarter people like you. Thank you so much.
Thank you, Dr. Basma, really for this wonderful, interesting presentation. Really, all of us enjoyed it very, very, very much. And now we know that DKA is getting very easy, and we will not behave like Kevin in the movie. When we are in the ER, we will be able to manage such cases. And now I'm inviting our three eminent speakers to join us for the Q&A session. So please, can we open the three cameras, the other cameras? Welcome back, welcome back. Yeah, I missed you really. Okay.
Missed you too.
Can we move now to the Q&A session, because we have a lot of questions from different audience. So I can start with the DK because we ended with this presentation. For Dr. Basma, there is a question asking you why in calculating all fluids we assume that the deficit is 10% dehydration, while some patients may come with mild dehydration.
Actually, Dr. Dua, all the guidelines, especially the SPIC guidelines, approve this. And I think DKA must be treated as regard the evidence-based guidelines. And this is the guidelines.
Yeah, sure. But I think also because the degree of dehydration could be mistakenly underestimated, because
معلش
due to
انا اسف
hyperglycemia.
دكتوره امينه انت عامله ميوت للصوت بس بعد اذنك. معلش اسفين على الانتربشن.
Yeah. Because in hyperglycemic, I think the dehydration will be underestimated.
I cannot hear you, Dr. Dua. I cannot hear you.
Sorry, I'm not muted.
Loud your voice.
Because I think also in patients with the DKA, the hyperglycemia will increase the osmolality and the dehydration will be underestimated clinically. So it's better for the safe side for the patient to make it 10% deficit rather than clinically we may underestimate it as a mild dehydration, but when we go inside the patient will be like more severely dehydrated. So I agree with you. We have to follow the guidelines, not the clinical presentation of the patient. Another question for you, Dr. Basma. They are asking you that in the use of ringer lactate, do you recommend it?
I cannot hear you.
Ringer lactate in DKA.
Ringer, yes, ringer is can be used. Crystalloid can be used. Yes, we can use it, especially as a bolus dose for volume expansion.
We have also a question for Dr. Amina. An emergency operation and patient has ketonemia. Shall we use bolus rapid-acting insulin and fluid? What do you think?
We have to assess blood glucose and ketones, and we have to manage. And if resolution occurs, we can proceed for the operation.
Thank you very much. For Dr. Rasha, there are a lot of people are asking about the genetic testing for monogenic diabetes. Is it available in Egypt?
Yes, I expected this question يا دعاء.
Sure.
الحقيقة although إن هي decisive فعلا زي ما قلنا, it is not available in Egypt, but it's easy to contact centers outside Egypt and send the DNA sample for genetic testing. And sometimes it's a part of clinical trials, so sometimes it's for free. I don't want to mention names, but there are centers. For example, in the UK, there are centers you can send the DNA, be part of research, and get the DNA result, because it's really important to know the results, especially in monogenic diabetes and the neonatal type.
And you answered the second questions, where to do genetic testing for neonatal and monogenic diabetes, so they will communicate with you and you can guide them.
Just send me an email and I can tell you, but I don't want to advertise.
Announce, yeah. Okay. Another question for you on the same topic, how we can change the treatment from insulin to sulfonylurea neonatal diabetes without genetic testing if we don't have a proof?
Yes, this could be a solution. It's not the ideal thing, but if you don't have the facility to do it, yes, you can give it a try. I think it deserves a trial. If you start on insulin, you taper the insulin very gradually and introduce sulfonylurea starting by 0.1 milligram per kg once a day, increase gradually until you achieve a good blood sugar. If the blood sugar is not increasing while you are weaning from insulin, this means that the case is not responding. This is a trial. It's not like doing the genetic testing, knowing the type of mutation and whether it responds or not. But I could say it's a solution. It's something, you know, to just save the situation. Yeah, it deserves to know.
Sure. At the same point, also, they're asking if we have no genetic test and we have neonate with diabetes, should we start with sulfonylurea first? You recommend that?
Okay, if the baby is presenting with DKA, you have to correct the DKA first, stabilize him, and then give it a trial. If it doesn't work, it will appear that it's not working, but not when the case is a DKA. You should correct the general condition first and give it a trial, and it will be evident. If you increase the dose up to 1 milligram, for example, and the baby is not responding, this means he will not respond. And in such a case, you will go for insulin.
Back again for insulin. Thank you very much. For Dr. Basma, there is a question for you regarding the DKA. They are asking you for a girl who is 3 years old, 10 kg, presented with moderate DKA, and managed successfully by giving Glargine and giving regular insulin later. After 4 days of treatment, she's still having blood sugar more than 400, 500, no ketosis. How can be explained?
What about the blood sugar?
400 and 500, but no ketosis.
Yes, I think there is a problem about the diet, the insulin dose, the presence of lipodystrophy. We must search for the cause of this hyperglycemia, because it occurs 4 days after the occurrence of DKA. And it may predispose the patient for another DKA. So we must search about the cause of hyperglycemia, whether it is error of the insulin dose, error of the diet, and so on.
Thank you. Another question in DKA, during management of diabetic ketoacidosis, the calculated insulin dose in fluid should be subtracted from the total calculated 48-hour fluid or not? So the insulin.
The initial dose of fluids?
Yeah, calculated insulin dose. He's telling about the amount of insulin.
Yes, the insulin dose about 50 centimeter. We put 50 unit of the insulin to 50 centimeter of saline. He mean that?
Yes.
He mean that?
Omitted? Yeah. You omit it? Yeah, usually you do?
I think, no, it is a very little amount. We talk about liters of fluids. So 50 millimeter doesn't concern.
Do not make a big change. And there is a question for Dr. Amina also regarding the sick day management. At which level of blood glucose we start corrective insulin dose in the sick day management?
After 250.
Thank you very much. And for Dr. Rasha also, they are asking, can neonatal diabetes suffer from other endocrine problems as hypothyroidism?
Yes, okay, but it's not a neonatal. There's something called monogenic autoimmunities. I touched on it. Monogenic autoimmunities, meaning that there is diabetes, there are other, like the APCID that I presented. APCID in the past was considered to be autoimmune disease, including type 1 diabetes. Nowadays, it's considered a monogenic autoimmunity. There are a lot of autoimmunities, including what we said, hypoparathyroidism, diabetes, but it is of genetic origin. It's not the typical type 1 diabetes. This is what we call the monogenic autoimmunities. This is the genetic type, not the classical autoimmune type, like APCID.
Thank you very much. And another question is asking you from Dr. Ahmed, what is the most solid criteria to differentiate between type 1 and type 2 diabetes?
Actually, sometimes the overlap is very difficult to differentiate, but DKA to a great extent, if the child presents in a bad condition, acidotic, this is very important. This is more towards type 1. If obese, this is more towards type 2. I'm saying more, but you couldn't say absolutely. And the high C-peptide, of course, if the C-peptide is high, this is towards type 2, because some type 1 at first do not have a very low C-peptide, but it will never be high. So if the C-peptide is high, you are more towards type 2. If it's low from the beginning, it's more towards type 1. And of course, complications are more, and obesity and acanthosis nigricans more towards type 2. But you can never say anything 100%. But whenever you are puzzled, it's type 1 until proved otherwise, because it's the most common type by far, except if it's so clear, obese, acanthosis nigricans, high C-peptide. If it's not like that, consider it type 1 until proved otherwise.
I agree with you. Another question for you: if patient with nephrotic syndrome on prednisolone and given insulin but still hyperglycemic, what's the solution?
You keep increasing the dose of insulin until normalized, and you keep following up the hemoglobin A1C. And then, as we said, it will either be steroid-induced diabetes, and once you taper the steroid, the child will improve gradually, or it is type 1 coincident as an autoimmune disease occurring with type 1, and in such a case, he will need insulin even when you stop the steroid.
What is the age limit approved for metformin, in your opinion?
Few years ago, it was 10 years. Now, according to the ISPAT guidelines, it's 8 years now. You can give metformin at the age of 8 years. And to be honest, I did it even at a lower age, because sometimes we see horrible numbers of insulin. The insulin is very high. Acanthosis nigricans is so marked, sometimes even lower than that. We have to give a very small dose to overcome the occurrence of type 2 diabetes. But according to the guidelines, it's 8 years now. This is the lowest limit.
And they are asking you also, what about the GLP-1 and bariatric surgery in type 1 diabetes?
No role. No role in type 1. It has got a role. Bariatric surgery, good. Yes, this is reductive surgery. It's with type 2. And it has been tried mainly in adults and in some adolescents, but not in type 1. Type 1, the cure is insulin, because a lot of patients come saying, please find me another treatment other than insulin, like surgery, like oral therapy. Unfortunately, till now, it's insulin, not the surgery.
Especially that the media is promoting for that surgery, and these things.
Yes, extremely. And they are trying to catch any hope. They are miserable, really. Type 1 diabetics and their families.
What's the meaning of HOMA-IR?
Homeostatic model for assessment of insulin resistance. Okay, this is a formula that gives a certain number. If the number exceeds 2, this is high, this signifies insulin resistance. If it exceeds 4.5, this is typically very high and going towards type 2 diabetes. But we use it to screen. For example, if I have an obese child, I ask for the HOMA and glucose insulin ratio to detect early the insulin resistance before type 2 diabetes. But once you have type 2 diabetes and the A1C is very high, it won't be of value. So it's important in the early stages before going into type 2 diabetes.
Thank you very much. When changing from Lantus to Tresiba, do we have to decrease the dose?
Not at all. You give exactly the same dose and reassess. Some of the patients require higher by time, you will test it, and some require the same dose and some require lower. But generally speaking, you give the same dose once a day. If the child is taking 2 Lantus doses, you add the 2 Lantus doses and give it in 1 shot of Tresiba.
Thank you. Another question: patient with type 1 diabetes and celiac disease, how to deal with?
It depends. If he starts as type 1 diabetes and the child starts to develop frequent attacks of hypoglycemia, anemia, weight loss, not gaining height, you suspect celiac disease. And as we said, even if not symptomatizing, we should screen for celiac disease at the diagnosis and every year. If it's proved, the child is put on a gluten-free diet. He will benefit from gluten-free diet. That's all for celiac disease, nothing else. And then you manage diabetes as usual, no problem. Once you correct the celiac, the blood sugar will go up again. He will not experience hypoglycemia as before.
Thank you, Dr. Rasha. Can we give you a rest and we can move to Dr. Basma for the DKA? Just back to the DKA, Dr. Basma.
Yes.
There is a question for you. They are asking you, is blood beta hydroxybutyrate available in Egypt? The test.
Yes. Yes. In some labs, and there are there is a bedside test by a finger stick strip, but I think the accuracy of it is not good. But lab is available in some hospitals.
Available. Thank you. Can we use Lasix in cerebral edema?
What?
Can we use Lasix, furosemide in cerebral edema?
It is not recommended. It is not recommended in cerebral edema with DKA. There is a difference between dealing with cerebral edema due to DKA and cerebral edema due to other causes, trauma or any other cause of cerebral edema. But in DKA, Lasix not used in treatment of cerebral edema.
Mannitol will do the job actually.
Yes.
What about the sliding scale?
What?
In DKA. Sliding scale in DKA. Any rule?
Sliding scale. It is not recommended in type 1 diabetes. Sliding scale may be used in type 2, not in type 1 diabetes.
Can we continue long-acting insulin during the DKA?
No, during the insulin infusion, we not use the basal insulin, but we can use it before the stoppage of the infusion. Maybe in the night before the morning stoppage of the infusion.
Thank you very much.
Especially in those known to be diabetic before.
Thank you, Dr. Basma. Can we move to Dr. Amina? Give her a long rest. Yes, Dr. Amina, there is a question for you. They are asking how to differentiate between stress hyperglycemia from diabetes, and if we can use from diabetes, and can we use insulin therapy in such cases? What's our target?
Stress hyperglycemia?
Yes. Yes, stress hyperglycemia and diabetes. How can we differentiate if there's hyperglycemia? Is it really diabetes? It's from stress?
You mean increase the counter-regulatory hormones that they constitute a factor for increasing blood glucose level, stress hyperglycemia, because of
increased ICU patients, like in ICU patients, they may have high blood sugar, maybe due to stress, or is it really diabetes? How to differentiate? Yeah,
we can assess other parameters like hemoglobin A1C, for example, and if we are thinking that it's type 1 diabetes, we can also assess the C-peptide and assess hyperglycemia, where is a transient case, and it will just resolve after the stress is over. So it's acute condition and will resolve after the stress. But we can be sure to, if we can perform other labs to prove or disprove type 1 diabetes, like C-peptide, like hemoglobin A1C, like the manifestation, also the
history,
the clinical picture. Yeah.
Thank you very much, Dr. Amina, for your
information. Another point, Dua, is that in stress hyperglycemia, the blood sugar usually doesn't exceed 300s. Not like the DKA. Sometimes it exceeds 500s and high numbers, but usually the stress hyperglycemia is around 300, doesn't exceed this range. It doesn't have the jump. It will not cause ketoacidosis.
Do you give insulin to them? For those patients with
yes, they have special protocols to be given. It's not like the DKA, they have special protocol. And of course, if you need to have a decisive decision, it's the A1C. If the A1C is normal, this means that this condition happened right now. If the A1C is high, this is diabetes, not stress hyperglycemia, like Dr. Amina said.
Sometimes the diabetes diagnosed before 3 months, which is the durability of hemoglobin A1C. So sometimes we misdiagnose a case of type 1 diabetes when the hemoglobin A1C not reaching to 6.5, and maybe due to the shorter duration of the onset of the disease. We depend mainly on the symptoms: polyuria, polydipsia, loss of the weight, and the patient not doing well in the last period. clinical picture is very important for the diagnosis of type 1 diabetes rather than the lab.
Symptomatology. Yeah.
Yes.
Yes, I think we should do both, supporting each other. We should fit the pieces together because you will not have a typical case in everything in the clinical and in the lab. But fitting them together, you will go which side?
Yes. Yes.
Based on fitting the pieces together.
And as Dr. Rasha with us in the screen, can we ask you, do we need to do antibodies in a newly diabetic patient to diagnose type 1 diabetes?
Actually, to be honest, we do not ask for it as a routine. Yes, it supports the diagnosis, but we cannot rely on this. As we said, consider type 1 diabetes is the most common type of diabetes in children by far. If it's not neonatal, if it's not mild asymptomatic hyperglycemia, if it's not an obese child with acanthosis nigricans, it's mostly type 1 diabetes. You do not need to do the antibodies in every case. It's just something to understand, something for research purpose, but we do not do it routinely. And another point is that, as I told you, it's one of the barriers. Some do not have positive antibodies, and they are type 1. Some develop antibodies later. So it's not a clear-cut thing that you rely upon. If it doesn't have the clear criteria of monogenic and type 2, it's type 1 then.
Thank you very much. Another question for you, celiac follow diabetes or diabetes follow celiac? Who's first?
Anyone could happen. It's an autoimmune disease. You can start by anything. Everyone has his own fate. He could start with celiac, then develop type 1, or start with type 1 and develop celiac. It's an autoimmunity. Anything could happen.
And is gestational diabetes in a mother lead to diabetes in children, especially if those children are obese? You think so?
Sorry, I didn't catch the question.
Gestational diabetes, if a mother with gestational diabetes, is it a cause for a diabetes in the child in the future?
Yes, this is for the case that I presented. Actually, the diagnosis of this obsessed mother that was thought to be gestational diabetes is another form of MODY. But the problem is that people do not think of MODY. They say type 1, type 2, gestational. The mother had mild hyperglycemia in pregnancy, and it proved to be MODY later on when genetic testing was done. So it's not the rule, but it could be a spectrum of MODY, to have a mom with hyperglycemia in pregnancy and then have a child with MODY diabetes as well, like the case that I presented. It's a spectrum, MODY spectrum.
By the way, Dr. Dua, 1/3 of females with gestational diabetes after labor, they become diabetic. 1/3 of them.
Yes.
Follow up of females
very
with
important.
It's very important postpartum.
Yes,
and
definitely. Yes.
I read also that their kids, the daughters, are certain percentage of them are susceptible to have type 2 diabetes later on in life.
Yes, yes. Type 2, or they could be a spectrum of MODY presenting with hyperglycemia in pregnancy, this or that.
Yes, yes.
Can Lantus be used below 1 year?
No, it's debatable. Actually, it's NPH. We use intermediate acting insulin. The best thing in the neonate or in a baby in the first year is to give the intermediate acting 2 to 3 doses, and you give the short or the ultra short acting on demand, especially in babies who are still suckling, who are still not eating, they're just suckling all the time. So it's not very much preferred. What we do is we give intermediate acting insulin, 2 to 3 doses a day, plus or minus ultra short if needed.
And what is the optimal age for Lantus?
Recently, it's not like before, 3 years, let's say 3 years.
And a female adolescent with type 1 diabetes has repeated hypoglycemia. Her hemoglobin A1C is high, about 14. Adrenal insufficiency and celiac disease, both are excluded, ruled out. What is your opinion, Dr. Rasha?
My opinion, there are a lot of cases, there are a lot of causes that could be incriminated. She could be, first of all, she's 14 years, and this is an explosion. She's a teenager. She could do anything. She could miss insulin doses. She could not adjust her diet properly. She could inject herself at any time or forget doses. She could not changing the sites of injection, so she develops lipodystrophy, so she's not receiving insulin. A lot of things need to be excluded. She could have a psychological problem. A lot of things could be the cause. So she needs proper assessment, history, looking at the family dynamics, revising the doses. At puberty, they need larger doses. At the time of menses even, they need larger doses of basal insulin. A lot of issues, especially in teenagers.
Thank you very much. For Dr. Basma, there is a question. They want to ask you about the management of severe hyperosmolar hyperglycemia without ketosis. If it is better to give insulin infusion, 10% of total dose of the insulin, what do you recommend?
Yes. The main problem, actually hyperglycemic hyperosmolar status is more prominent in type 2 diabetes, but may occur in type 1 diabetes and neonatal diabetes. The main problem is the hyperosmolarity. So volume expansion is very important. Potassium supplementation is important. About the insulin, it must be given in a lower dose, maybe 0.3 unit per kg per hour. The main target is the expansion of the volume in cases of hyperosmolar hyperglycemic status.
Hydration. Thank you, Dr. Basma. There is another question for you. They are asking you if a shocked patient with the DKA, also the bolus should be deducted.
What again, please?
If a patient coming with a shock and DKA, you also subtract the bolus from the fluids?
Shocked, yes. He shocked. We must give the bolus quickly to have expansion. He is shocked, right?
And after that, you will take it from the total amount of the fluids. You will subtract it.
Yes, it must be. It is a large amount, 30 milli per kg, and may be repeated. Yes, we must subtract it from the total fluids.
Another question, there are a lot of questions, but I think most of them you answered during your presentation. You covered the topic, and a lot of the audience are asking for the presentation of Dr. Amina, Dr. Rasha, and Dr. Basma. So I think it will be available in the site somewhere, and they are sending their mails asking for the presentation because all of them enjoyed and maybe they need it as a reference for that. I think we covered most of the questions now, and we can thank you for the elegant presentation, and we thank you for this great fruitful discussion and for this very, very informative night. And I think we finished the third girl in our endocrine chain, and we are really delighted to, I was very delighted to moderate this informative, comprehensive session. And I would like to thank my eminent top speakers, Dr. Rasha, Dr. Basma, and Dr. Amina. And I would like to thank also the audience for attending and staying for us till now. There is a big number staying till now. And they participated and they enriched the discussion with their important question. And without them, we couldn't make it this time. And a special thanks for Dr. Muhammad for staying with us till now and for mastering this session. And our prayers for Dr. Wael at the end. And we also give our special thanks for the organizing company and for their support and for the arrangement and the support all over the presentation. And thank you very much for staying with us, and thank you for your input.
Thank you very much, Dr. Dua. Thank you very much.
Thank you, Dua, for the perfect moderation. Thank you very much for mastering the session and moderating and distributing the questions very much. Thank you.
And thank you very much, Dr. Rasha and Dr. Basma. I'm really very happy to be with you in this session.
Thank you very much, Doctor. I mean, my pleasure to be with such elegant group, Dr. Basma and Dr.
Muhammad, Dr. Dua, for me to be with you and spend this wonderful time. And thanks for the attendees. And I'm sorry for the interruption. It is not because me, it is because of the internet. I'm so sorry.
ربنا يبارك فيكم يا رب جميعا، واحنا بنشكركم على تعبكم ده، وربنا ان شاء الله يعني يرجع لنا الدكتور وائل قريب ان شاء الله ويكون معانا، لان هو وحشنا ووحش كل الناس ان شاء الله. وربنا يبارك فيكم يا رب، ونشوف اقرب فرصه يبقى معانا باذن واحد احد ان شاء الله
باذن الله.
ومتشكرين جدا على تعبكم معانا، وربنا يجعله في ميزان حسناتكم جميعا، وان شاء الله نلتقي قريبا على خير باذن الله.
ان شاء الله. ربنا يطمنا على دكتور وائل يا دكتور محمد، ويعني شاكرين لمجهوداتكم في الكونتينيوس ميديكال اديوكيشن، حقيقي حاجه جميله ومثل يحتذى بيه، يعني فعلا ربنا يجعله في ميزان حسناتكم، حاجه جميله ورائعه، ربنا يقدركم كمان وكمان، ويرجع كده الدكتور وائل وكل حاجه تبقى جميله زي الاول واحسن.
اللهم امين، ربنا يبارك فيكم يا رب ويحفظكم.
شكرا يا دكتور
انت
محمد.
حضراتكم عملتوا حاجه جميله قوي يا دكتور محمد، ويا ريت تبلغها الدكتور وائل. انتوا عملتوا لنا زي جامعه الدول العربيه كده، بس انتوا عملتوا لنا مجموعه من كل الجامعات المصريه، يعني وان يونيون، ودي حاجه جميله جدا جدا، لان احنا وي ميس ذا كوميونيكيشن يعني في الوقت الحالي.
شيرنج اكسبيرينس، حاجه
فجزاكم
جميله جدا.
الله خيرا ان انتوا جمعتونا كلنا على قلب رجل واحد، هدفه ان احنا يعني نوصل بمستوى علمي يليق بالمريض المصري، لان هو يستحق فعلا ان احنا نعتني بيه.
ربنا يا رب يبارك فيكم جميعا يا رب. والفيدباك حتى من الدول العربيه اللي بيجي لنا ان ناس كثيره زي ما انتم بتشوفوا حضرتك في البارتيسيبانتس اللي موجودين من كل الدول العربيه ومتابعينا، وربنا يا رب.
وفي دول كمان مش عربيه يا دكتور محمد، في عربي ومش عربي. في ناس طلبت مننا to speak in English all the time because they are not Arab speaking countries، فالحقيقه عربي ومش عربي كمان ما شاء الله.
ربنا يا رب يبارك فيكم، وده بفضل الله سبحانه وتعالى، ثم دعمكم لنا الدائم ده. ما هو لولا انتم يعني اساتذتنا الكبار بتستجيبوا وتدوا للناس العلم بتاعكم، والناس اللي بيحضروا وبيشوفونا ما كانش هيبقى لنا اي قيمه.
لا ازاي
ربنا يبارك فيكم
في اي وقت، تحت امركم في اي وقت.
ربنا يبارك فيكم يا رب، وتصبحوا على خير يا رب،
تصبحوا على خير،
ولا تنسوا الدكتور وائل من دعواتكم.
طبعا اكيد،
الله
يرجعوا بالسلامه ان شاء الله.
ترجعي بالسلامه
سعيده جميعا.
ترجعي بالسلامه.
الله يسلمكم، الله يسلمكم، ان شاء الله اشوفكم قريب، بس الطيران اشتغل ان شاء الله.
دكتورة دعاء، شكرا.
تسلموا.
تصبحوا على خير.
مع الف سلامه. مع السلامه.
الله يسلمك.